Hello dear student, a very good evening to all of you. I hope all of you are doing good. So, just give me a confirmation whether I am clearly audible and visible to you or not. Just write down yes whether I am clearly visible to you or not, then we will start the session. Right, perfect, very good. Thank you so much for the confirmation. So, I hope all of you are doing good. So, today we are going to discuss some image based question which are very important for INI-CET type of examination, right. So, before this session, you know, I had also taken another session of image based question on YouTube platform only, and that is for NEET PG marathon. Okay. Now, I advise you, all of you, please listen this session also, as well as also watch the previous session image based questions. If you follow both of these image based question session, I think most of the important images in physiology will be covered up, right. So, in that way, please at least look at the image and their answer from both the session, in today's session as well as there is a previous session, right. So, we will start the session, but before that let us see. Okay, namaste, good evening to all of you. I am not taking the name of student, but I can see many of you have joined. Yes, image in physiology means mainly the graphs and chart, right. Right, very good. Class is approximately 2 hours. It may increase or may decrease, I do not know, depending on the discussion. So, let us start, right. Okay. So, I think all of you are comfortable. Now, before starting, here is the important topic for INI-CET examination, or I should say these are the must know topic for INI-CET examination. You have to read at least this many topics for physiology. What are those? So, first of all, whenever you are looking at the gain of the control system, I hope all of you know that in AIIMS the gain calculation, there will be a problem, and from that problem gain calculation will be given. So, you must have to look at the formula of gain and how it is calculated. Second is the Nernst equation formula, you know, the different concentration of ions will be given, right, and depending on that concentration you have to calculate the Nernst potential of different ion. Okay. So, you have to recall or you have to remember the whole Nernst equation. Whenever I am saying the third topic, the ionic basis of RMP and action potential, you have to know what is the most important ion for RMP and what are the different ion channel responsible for action potential generation and what are the different phases of action potential. This is the basic minimum, bare minimum thing that you must have to read, right. Next topic is the excitation contraction coupling. Here the most important thing that you have to learn is the coupling between the DHPR and RYR receptor. Okay. So, that is one of the important topic where INI-CET is targeting in the recent years. So, you have to read and you have to understand this topic, right. Okay. Then Rensa cell inhibition, you know, you have to identify the where the Rensa cell is present, what is the neurotransmitter and what kind of inhibition this is. Then muscle spindle and Golgi tendon Golgi tendon apparatus, right, Golgi tendon organ. These two receptor, they are under the proprioceptor, and I hope all of you have to remember that what is the most important stimulus for this muscle spindle, what is the most important stimulus for this Golgi tendon organ, and related thing you have to also look at like stage reflex and invert stage reflex. Now, then type of memory, sometimes the AIIMS also ask that giving you an example, clinical example, they will ask that which type of memory the student or the subject is recalling. So, that way you have to identify that whether it is short term memory, whether it is working memory or long term memory, or you know that implicit or explicit memory. So, this type of classification you have to just remember the classification, different type with their examples. Looking here on the other side, JVP and PV loop, you know that what happens to the PV loop in different valvular disease, like for example aortic stenosis or aortic regurgitations, as well as you have to read the Bain-Bridge reflex and Bejold-Jaris reflex. AIIMS has asked many questions from these two reflex. So, this is also one of the very important topic. Then flow volume loop in disease condition, you know, obstructive restrictive disease as well as the upper airway obstruction and the lower airway obstruction diseases, what will happen to the flow volume loop, that is also important. Regulation of respiration, particularly the pacemaker and the importance of the other center, right. So, that you also have to read from this, And then high altitude physiology, they mainly ask you what is the treatment of different high altitude pathological condition, like for example acute mountain sickness, they often ask high altitude pulmonary edema and high altitude cerebral edema. So these three diseases you have to read whenever you are reading this high altitude physiology. Not only that, how the acclimatization or how the adaptation occurs in high altitude physiology, this is one of the important or pet question in INI-CET type of examination, right? And glucose and water reabsorption in kidney, you have to look at the receptor, where this receptor are located and how the glucose is absorbed and how the water is absorbed in different parts of nephron. That is the bare minimum thing. GFR autoregulation, you have to remember the three primary mechanism of GFR autoregulation. All of you know the autoregulation mechanism, right? Tubuloglomerular feedback mechanism and the renin-angiotensin system mechanism. So these three mechanism you must have to read about this GFR autoregulation. Hormone receptor, you know, so this hormone receptor, what hormone act through which receptor, that is also a single liner question in INI-CET, okay. And then BER in GIT, basal electrical rhythm or basic electrical rhythm. I will discuss a little bit about this BER in my class, and some other topic will also cover up in this session. So let's start, okay. So thank you so much for wishing me good health. Yes, I am doing fine nowadays. Gain of the control system, okay. In this session I am not going to discuss, but gain is correction upon error. That is a formula which is known as the gain of the control system, okay. So that is correction upon error. So if a system is fully 100% foolproof system, then error is 0, then gain is infinity. This kind of question has been asked in INI-CET, and the example of the infinity gain is kidney, okay. But you have to read a little bit about gain, because other problem has also been given from gain of the control system, okay. Now okay, very good. So now we are going to the first questions. So look at the question. This questions is a new questions. In my session, some of the questions are already previous year question, and some of the questions are new questions. So I want to give you some concept of some important topic. First important topic is the exercise physiology. You know, in AIMS and in INI-CET, exercise physiology is one of the important thing you have to understand. So first question is related to the exercise physiology, right? Okay. So look at the question and try to guess your answer first, then I will give you the explanation, okay. One of the very important MCQ here. So effect of isotonic exercise. So whenever you are reading at the question, first of all you have to look at that what kind of exercise they are saying. All of you know that isotonic and isometric, though both are the two different types of exercise. So here isotonic exercise is in the question, and they are saying the muscle blood flow of the leg muscle, the cup muscle of the leg blood flow has been shown here, and the blood flow was much less during contraction, and in between contraction blood flow increasing, right. Now they are asking rhythmic increase in blood flow. So what is the cause of this increased blood flow during relaxation of the muscle, right. So whenever you are doing exercise, okay, what is the cause of increased blood flow to the muscles, right. 4 options are there, try to guess your answer, okay. Okay, so I have got one answer from Dr. Minu, B, Dr. Vishal is also saying B, okay, Dr. Bhai, happy vibes, okay, so A, C, right. And if I ask you, okay, so whoever has answer, now all of you start thinking that which of these 4 options is not responsible for increased blood flow to the muscles. Getting my point? Okay. Here the question answer that I will tell you, but suppose the question is in a reverse way, that which of the following is not responsible for increased blood flow in the calf muscle of human, okay, right. So try to think that you do not have to answer, you try to answer in this question A, B, C, D, what is your option, okay. So many of you are saying A, many of you are saying B also, okay. Cholinergic sympathetic system, no, cholinergic sympathetic system is not the answer here, okay. So let us look at, so first look at the curve, what the curve is saying, okay. So the curve is saying that there is increased blood flow and there is decreased blood flow. So increased blood flow when the muscle is relaxing and decreased blood flow when the muscle is contracting. This is a type of isotonic exercise. You know that isotonic exercise means if I do a kind of exercise like this, okay, suppose I am exercising like this. So this is a typical example of isotonic exercise. All of you must have done this kind of exercise, right. So this is isotonic. Here the load or the tone is same, but your length of the muscle is changing constantly. So, this is isotonic kind of exercise. I will also tell you what is isometric and what happens in isometric exercise, but before that. So, here I can find out that there is increase in blood flow to the muscle, increase in blood flow to muscles, okay, when the person is doing exercise, and we have to understand that what is the cause of increased blood flow to the muscle, right. Now, Guyton is saying that the capillaries which is supplying the blood to the muscle, suppose this is the arterioles and these arterioles are giving rise to capillaries, right. So, arterioles and these are the capillaries which are supplying blood to the muscles. So, 4 capillary I have made here, okay. Just imagine this diagram like this, that this is the arterioles, it is bringing blood to the muscles, and these are the capillaries which is supplying the blood to the muscle. In resting condition, you have to remember the value. In resting condition, when the muscle is not doing any exercise, in that condition the blood flow to the muscles is around 4 ml per 100 gram of muscle tissue per minute. Remember this value. Sometimes they also ask you direct question. So, Guyton is saying it is 1 to 4 ml per 100 gram of tissue per minute, means this much of blood flow is very less, okay. बात समझ में आ रहा है. That means in resting condition muscle blood flow is very less. Question is why? The answer that most of the capillary in resting condition remain in a closed condition into the muscles, okay. So, because the capillaries are closed, so obviously blood flow will be lesser in muscle, resting muscle. But whenever the person is doing exercise, now the person is doing exercise, so what will happen? More and more capillary will open up. So, the closed capillary, they will start opening up again and again, more and more, recruitment of more and more capillary. Now, how the capillary will open up? If you increase the blood pressure of the subject, so the blood pressure will try to open up the capillary, but they will not be able to open up the capillary completely, because you know that there is a sphincter at the beginning point of this capillary, which is known as the precapillary sphincter, which is known as the precapillary sphincter, very important. And this precapillary sphincter can only be opened up by local metabolites of the muscles. It cannot be opened up by sympathetic parasympathetic system, because there is no innervation of sympathetic and parasympathetic system on the capillary. So, this precapillary sphincter can only be opened up by metabolites inside the muscles. So, what is the most important metabolites that open up this precapillary sphincter? You have to remember this name: adenosine, potassium ion, lactic acid, carbon dioxide. So, these are the metabolite, but most important metabolite that you have to remember, that is adenosine. So, this adenosines, potassium, lactic acid, carbon dioxide, all of them, they will causes opening up of more and more capillaries by opening up of the precapillary sphincter, as well as recent edition of Guyton is saying that this metabolite can also causes dilatation of these arterioles, dilatations of these arterioles. So, you are dilating the arterioles as well as you are opening up of the more and more capillaries. So, obvious thing is that the resistance, all of you know that the arterioles are the vessels which is responsible for resistance to blood flow, total peripheral resistance, the most important site is arterioles. So, if you causes dilatation of the arterioles, so your resistance is decreased, then you are opening up of the capillaries. So, what will happen? Huge amount of blood flow will enter inside the muscles. That is why we say that during exercise, this resting blood flow can increase up to 25 times than that of the normal. And what is the most important cause? The most important cause is local metabolite mediated vasodilatation. Okay? So, this is known as the metabolic vasodilatation, and Guyton is saying that this metabolic vasodilatation, so metabolites vasodilatation is responsible for 50% increment of blood flow, right? Right? Okay. So, that is the most important thing. Now, is there any other cause? Yes. So, this is the most important cause, but that does not mean the other cause are not responsible. Yes. So, increased blood pressure is 30% contribution for increased blood flow to the muscles. I told you already, if your blood pressure is high, so you have already dilated the arterioles and you have opened up the capillary. So if your blood pressure is high, the blood pressure will push more blood into the muscle. So that is, increased blood pressure is also responsible for increasing blood flow to the muscle. But first of all, you have to open up the capillary, and that's why the maximum contribution is metabolic vasodilation, second contribution is increased blood pressure, and the third contribution is sympathetic mediated vasodilation into the muscle by beta 2 receptor. All of you know that alpha receptor will causes vasoconstriction, but skeletal muscle mainly have beta 2 receptor, because of which whenever the sympathetic is stimulating this beta 2 receptor, vasodilation will happen. So if I go back to the question, increase arterial blood pressure, it is responsible for 30% contribution, metabolic vasodilation 50% contribution, sympathetic mediated beta 2 mediated vasodilation, it is remaining approximate 10 to 20% contribution. And this cholinergic sympathetic system, this is also a cause of increased blood flow to the muscles, but not in human being. It is responsible for increased blood flow to the muscles in lower mammal, like for example cat, dog. In these mammals, when the experiment has been done, this cholinergic sympathetic system is also responsible there, but not in human, not in human. So if I have to answer that which of the following is not responsible for increased blood flow to the muscles during exercise, then I will go for this D. But here the question is asking which is the most important cause of increased blood flow to the muscle during exercise. Your answer is metabolite mediated vasodilation. Am I clear to all of you? Please tell me whether this is clear to all of you or not. This is very, very important. I am telling you, anytime they will ask you question from here, exercise physiology, at least 10 to 12 question has been asked only from exercise physiology in INI-CET. Okay? So this is clear to all of you? Okay? Right, very good. So metabolic vasodilation and adenosine. Okay? You should not forget this. Rhythmic, because whenever you are contracting the muscle, there is compression of vessels inside the muscle, so that time blood flow cannot increase because you are compressing the vessels as well as capillary. Now you are relaxing, blood flow will suddenly increase. Again you are contracting, the blood flow will decrease. Again you are relaxing, the blood flow will increase, right? So this is the scenario which is going to happen, but whenever the muscle is relaxing, okay, the huge blood flow, okay, because of vasodilation, and because of vasodilation, what will happen to the TPR, total peripheral resistance, that will also decrease. Please remember, total peripheral resistance is one of the important sensitive marker in examination, you know. So total peripheral resistance से क्या हो रहा है ये आपको ध्यान देना होगा. And during exercise, isotonic type of exercise, what will happen to TPR? TPR will decrease, okay, in case of moderate to severe. I will come to this point once again, but before that I hope this is clear to all of you. Now I will go to the next question. PDF will be given to you, don't worry, right? So next question. Now this is one easier question, but related to exercise, because today my main aim is to give you a concept of exercise physiology at the beginning, then I will go to the other questions. So now look at the questions and try to answer. So you have done the recording of blood pressure, systolic blood pressure, diastolic blood pressure, mean arterial pressure during isotonic exercise. So again the isotonic type of exercise, curve A, B, C represent which kind of blood pressure, means you have to identify curve A is what, curve B is what, curve C is what, which blood pressure, that is the question here. And if you look at this diagram carefully, so here is one diagram given, and what is the diagram? The diagram is the one person is doing cycling, okay. So cycling in which kind of exercise? Again it is a kind of isotonic exercise, right. So this isotonic exercise is going on. This is the resting condition, then this is 25, 50, 75 and 100% of VO2 max. VO2 max, I hope you must have heard about this VO2 max. VO2 max is the maximum amount of oxygen that can be consumed by a person during severe form of exercise. So this VO2 max you have to understand, right? Okay. So whenever you are doing more and more severe exercise, okay, if you are doing very severe exercise, what is the maximum amount of oxygen you are consuming, your body is consuming, that is a VO2 max. If you are consuming only 25% of your VO2 max, then we say that this is a kind of mild exercise the subject is doing. If you are consuming 25 to 50% of the total VO2 max oxygen consumption, then we say that the subject is doing moderate kind of exercise. Whenever the person is consuming 50, right, 50 to 75% of the VO2 max oxygen, then we say the subject is doing heavy exercise. And when the oxygen consumption of the subject is beyond 75 to 100% of VO2 max, then the person is doing very heavy or severe exercise, right. So, this is the grading of exercise according to WHO criteria, right, that you have to also remember. Okay. So, if you are consuming less than 25% of VO2 max, mild exercise, 25 to 50 moderate, greater than 50 to 75, that is a severe, okay, or heavy exercise, and whenever it is greater than 75, that is very heavy or severe form of exercise, right. So, heavy and very heavy or severe form of exercise. So, these are 4 type of exercise grading. So, whenever the subject is doing more and more type grading of exercise, what you are finding out, the curve A is showing this kind of blood pressure is rising more and more, and that is very steep rise of increased blood pressure. Second one, blood pressure is also rising, but this is mild increase in blood pressure. But third curve is a little different. Here I can find out the blood pressure initially is decreasing a little bit, later on it is decreasing to a very high level. So, I have to identify what is the blood pressure in this 3 curve. Okay. So, this is you have identified, all of you have identified, and this is easy. Why easy? Sometimes suppose you do not know the concept of this question, then what will you look at? You will look at that what is the starting point of this blood pressure. Here is the starting point of this blood pressure, this is the resting condition. So, the resting condition, the blood pressure is 120. So, what blood pressure this is? Obviously, this is going to be my systolic blood pressure. Then this is the starting point, this is 100. So, this is basically your mean arterial pressure, and this is in and around 80. Okay. So, this is my diastolic blood pressure, right. So, even if you do not understand the concept of the exercise physiology and blood pressure, then also you can identify that A is systolic blood pressure, B is mean arterial pressure, and C is the diastolic blood pressure. So, your answer will be D, but yes, right. Okay. So, you have to identify that, okay, because ultimately you have to answer, okay, whether you understand it or not understand, but you are guessing the answer correctly, that is ultimate thing. But here I will say the question may be different, okay, here the question is simple, but question may be different. So, you need a concept, little concept about this blood pressure and exercise. So, look at, okay, very very important. So, the person is doing isotonic kind of exercise, the person is doing isotonic kind of exercise, right. Okay. What will happen to the cardiac output of this person? The cardiac output will increase. Okay. Now, this increase in cardiac output is because of increase in stroke volume as well as increase in heart rate, because we all know that cardiac output is the multiplication product of stroke volume and heart rate. Now, if you look at the pattern of cardiac output increment, that can also be an MCQ in future. So, look at, suppose the person is doing more and more severe form of exercise. So, this is mild exercise, this is moderate exercise, this is severe or very severe exercise, whatever, and you are measuring the cardiac output parameter. So, what will happen? You will find out that cardiac output increases linearly along with the increase in intensity of the exercise up to a peak point. After that peak point, the cardiac output will plateau. So, this is the increase in cardiac output. If you look at the increase in heart rate also increases in parallel to the cardiac output increment up to a maximum limit. So, this is also the increment of heart rate. So, this is very simple, that heart rate and cardiac output, they are increasing proportionally parallelly up to a peak point. But if you look at the stroke volume increment, then the curve is a little bit different. You have to look at this curve. So, increase in stroke volume initially is very very high, but after a little time point the stroke volume increment cannot increase further. Stroke volume increment is not there, means stroke volume is rising initially, but later on there is a plateau in stroke volume increment. So, how the question will be asked from here? See, Guyton is saying that the stroke volume plateau occur when cardiac output has reached 40 to 50% of maximum increment. Getting my point? What I am saying, suppose normally my cardiac output is 5 liter per minute. All of us know that normal resting cardiac output is 5 liter per minute. During very severe exercise, how much cardiac output increment can occur? What is your guess? How much? How much cardiac output increment can occur if you do a very severe kind of exercise by athletes or trained athletes? They can increase their cardiac output up to 7 times, means 35 liter per minute can be increased. So, Guyton is saying that maximum cardiac output that can be increased up to 35 liter during very severe form of exercise. Now, just take what is the 50% of 35 liter. Okay. So, it is in and around 16-17 liter, right, aspas. So, Guyton is saying whenever the cardiac output has increased up to 40 to 50% of maximum increment, then the stroke volume will plateau. Stroke volume cannot increase further. Why so? Because you know the stroke volume depends on the end diastolic volume. Now, whenever your vein is pumping more and more blood, your venous return will be high and there will be increase in end diastolic volume of the heart, but it has a limitation now. If you push huge amount of blood to the heart will not be able to accommodate huge amount of blood because there is a limitation of end diastolic volume, and because of that limitation the stroke volume also get plateau, right. Now, second thing is that the question will be asked that when the person is doing exercise initially, what is the cause of increase in cardiac output? Your answer will be that in initial cases increased cardiac output is due to increase in stroke volume also as well as increase in heart rate also. But if I ask you that cardiac output increment after 50% increase in cardiac output, what is the cause of increased cardiac output during that time? Do you think stroke volume contribute to the increase in cardiac output during that time? Answer is no, 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 because after this 50%, the remaining part of the cardiac output increment is only because of heart rate increment, because stroke volume is constant, stroke volume is plateau. So, please note down that although we say that increased cardiac output is due to increase in stroke volume and heart rate, but that is not true. Initial part both are responsible, but later part after 50% increment only heart rate is responsible for increase in cardiac output. Now, if I ask you why the stroke volume is increasing during exercise, your answer will be that there is increase in end diastolic volume as well as there is decrease in end systolic volume. Look at, there will be increase in end diastolic volume. Why the end diastolic volume will increase? Because of increase in venous return. All of you know that during exercise your muscles, peripheral muscles are pumping the blood towards the heart. So, venous return is high, end diastolic volume is high. And why end systolic volume will decrease? Because the contractility of the heart has been increased because of the sympathetic discharge. So, if you cause a strong contraction of the heart, the remaining blood after contraction, that is the end systolic volume, that is going to decrease. So, your end systolic volume is decreasing and your end diastolic volume is increasing. Both are responsible for increase in stroke volume. Getting my point? And what is the cause of increase in heart rate? Now, here there is an MCQ which has been asked in INI-CET kind of examination. The heart rate increment during exercise can occur even before the start of exercise. This has been asked in INI-CET AIIMS examination previously. Even before the start of exercise. If I ask you, ki bhaiya, you have to do exercise on this treadmill for the next 1 hour. So, you will start thinking that sir has told to the exercise and you are a sedentary person. So, आपका तो हो जाएगा ना, means you will start thinking that you have to start exercise, and that thinking will start your increase in heart rate, your increase in respiratory rate also, and we call that this kind of stimulation is known as the psychic stimulation. Yes, feed forward mechanism. This is known as a psychic stimulation, and this is a kind of feed forward mechanism. Yes, anticipatory increment in heart rate. Okay, and later on the heart rate increment is due to the obviously sympathetic system stimulation. Got it? So, this is the increase in stroke volume, increase in heart rate, increase in cardiac output. Now, whenever your cardiac output is high, cardiac output is a direct determinant of systolic blood pressure. So, your systolic blood pressure will also rise. Okay, right. Now, diastolic blood pressure is determined by two things. One is elastic recoiling of the arch of aorta, and second is total peripheral resistance. Mark my word, this has been asked in AIIMS, that what is the main determinant of diastolic blood pressure? Elastic recoiling of arch of aorta, and second is the total peripheral resistance. Now, whenever the person is doing isotonic kind of exercise, previously we have discussed that there is vasodilatation. What kind of vessels dilatation is occurring? arteriolar dilatations is happening, and arterioles are the main site of total peripheral resistance, right. So, whenever there is dilatation of the arterioles, the total peripheral resistance will be decreased, particularly in moderate to severe kind of exercise. If you are doing mild exercise, total peripheral resistance may not change significantly, but whenever you are doing moderate to severe kind of exercise, your total peripheral resistance is going to fall, and whenever your total peripheral resistance is falling, your diastolic blood pressure will also fall. So, this way you have to remember that in case of isotonic exercise, systolic blood pressure will rise, but diastolic blood pressure will fall. And if you look back at the graph, now you look at this red color curve that we have seen previously. So, this red color curve is showing that initially the diastolic blood pressure was falling a little, later on the diastolic blood pressure is falling to a very high level, and this fall in diastolic blood pressure is due to decrease in total peripheral resistance. Now, the systolic blood pressure is rising proportionally more and more because of the increase in cardiac output. Now, you all know that mean arterial pressure is the average of diastolic and systolic blood pressure, 2/3 of diastolic and 1/3 of systolic. Although diastolic blood pressure is decreasing, but systolic blood pressure has increased to a very high level, because of which the mean arterial pressure is also going to rise a little bit. That is why the curve is looking like this. So, our answer is this, the answer is D. All of you now tell me whether you get this thing or not, that what happens to the blood pressure during isotonic kind of blood pressure, isotonic kind of exercise. Got it all of you? Just give me a thumbs up whether you are getting it or not. Yes, preload is same with that of the end diastolic volume. Yes, and afterload is the aortic pressure, the TPR is the determinant of afterload, right. Got it. Okay. Now, the main confusion arises when the question is asking about isometric exercise. So, little bit about isometric exercise, I hope this will clear your doubt. Isometric kind of exercise, okay, isometric. Now, isometric exercise example, all of you know that if you try to push the wall, okay, obviously you will not be able to push the wall, but if you go on pushing the wall more and more, so what is happening? The length of this muscle is not changing, okay, but you are pushing more and more on the wall. So, your tone is increasing more and more, your pressure is increasing more and more, but the length of the muscle is fixed. Isometric, metric is length. So, when the length of the muscle is fixed, but tone or load on the muscle is rising more and more, then that is known as isometric exercise. I give this kind of example in my class, that when a weightlifter is lifting the load, suppose I am a weightlifter, obviously I am not, okay, if you look at me, obviously I am not looking like a weightlifter, but suppose I am lifting 100 kilo weight from the ground. Whenever I am lifting this load from the ground, that is a kind of isotonic exercise, but after lifting this load, if I hold the load like this, straight hand, I am holding the load over my head for 2 minutes, I am holding the load like this. So, is there any change in length of this muscle during this kind of exercise? Answer is no. You are only holding the load, but there is huge amount of tension, huge amount of load is falling on your muscle, and that load is more and more, okay. But your muscle length is not changing, your muscle is strongly contracted, but your length of the muscle is not changing. This is a typical examples of isometric exercise, where your whole body muscles are strongly contracted to lift the load over the head. Getting my point? Now, whenever the person is doing this kind of isometric exercise, what will happen to the cardiac output of this person? Cardiac output will increase or not? Cardiac output will increase or not? Okay. Obvious thing is that it is a very severe form of exercise. Isometric exercise is severe form of exercise. Cardiac output has to be increased. Now, in these cases, please note down, in case of isotonic, we told you cardiac output increase occur because of increase in stroke volume as well as because of increase in heart rate. In case of isometric exercise, stroke volume increment is not going to happen, it remain constant. It has been asked in MCQ INI-CET exam, but heart rate increment is going to happen more and more, along with the exercise. So, if I ask you that in case of isometric exercise, what is the cause of increased cardiac output, your answer will be it is dominantly because of heart rate, because stroke volume increment does not happen, it remain constant. Now, obviously you are thinking that why stroke volume will not increase, sir? Okay. Now, look at what is the determinant of stroke volume. Stroke volume depends on what is the end diastolic volume, and end diastolic volume depends on what is the venous return, right. Now, venous return to the right heart, right atrium that we are talking about. So, whenever you are holding the 100 kilo load above your head, what is happening to your thoracic muscle? Your thoracic muscle are strongly contracted. Now, if your thoracic muscles are strongly contracted, mean you are putting more pressure on the heart, your intrathoracic pressure is high. Yes, your pectoralis muscles and all muscles are strongly contracted. So, you are increasing the intrathoracic pressure, you are giving compression on the heart. So, what will happen to the return of blood to the heart? It is opposing because of strong contraction of this muscle from the thoracic wall. Secondly, whenever you are holding this load, your lower limb muscle is also acting, your upper limb muscle are also acting. So, more blood is trying to return to the heart, but because of the contraction of the thoracic muscle, more blood is not able to enter in the heart. Getting my point? So, because of the strong contraction from thoracic wall, it is a opposing force for venous return, and the muscle is pushing the blood, that is a positive force for venous return. So, one force is positive, one force is opposing. Because of these two force, because of the tussle between these two force, stroke volume cannot increase to a very high level, or stroke volume cannot increase at all. Okay. That is why we say that when the person is doing severe form of isometric exercise, stroke volume remain constant and cardiac output increment is only because of heart rate increment. But whenever cardiac output increases, what will happen to the systolic blood pressure? Systolic blood pressure will also increase. Got it? So, this is first thing. Now, second thing, what will happen to the diastolic blood pressure? We have earlier discussed that diastolic blood pressure depends on the total peripheral resistance. So, when the person is holding the load like this, what is happening? These muscles of the hands and the muscles of the other part of the body, they are strongly contracted. Do you think is there any in between relaxation like that of the isotonic exercise? In isotonic exercise, there was relaxation in between, that is why blood flow was increasing suddenly, but here there is no in between relaxation, only strong contraction of the muscle, and when the muscles are strongly contracted, the vessels, the capillaries which are present in between the muscle, they will also remain in a contracted state, and when the vessels remain in a contracted state, your total peripheral resistance will be very high, and because of the high total peripheral resistance, the diastolic blood pressure will also be higher. So, in case of isometric exercise, systolic blood pressure will be also high, mean arterial pressure will be very high, and diastolic blood pressure will be also very high. Getting my point? In case of isotonic exercise, we have seen that diastolic blood pressure is never increasing, rather it is decreasing in severe exercise, and mean arterial pressure was never increased to a very high level. There was mild increase in mean arterial pressure in isotonic, but here the mean arterial pressure will also increase to a very high level. That is why you know that because this isometric exercise is rising your diastolic blood pressure to a very high level, as a doctor you never prescribe isometric kind of exercise for physical fitness, but we prescribe aerobic exercise, isotonic kind of exercise, because whenever you are rising your diastolic blood pressure to a very high level, it is going to increase the mean arterial pressure, and that is damaging, right. So, this is the thing that you have to remember. So, most important thing that I have to remember is that in case of isometric exercise, stroke volume remain constant, TPR increases according to the grade of exercise. If the isometric exercise is mild, then TPR may be normal, but TPR will never fall. If the isometric exercise is very high, then TPR will also increase proportionately. Getting my point? So, this information is very crucial in INI-CET examination. All of you tell me whether this is clear to you or not. Okay? Yes, stroke volume during breath holding, this is the same reason. Whenever you do inspiration, your stroke volume increases because of the same reason, because intrathoracic pressure decreases, and whenever your intrathoracic pressure increases, your stroke volume has to be decreased. Pulse pressure, yes, that is systolic minus diastolic blood pressure. If the TPR increases, how the positive pressure of blood try to enter the heart. There is a steady state condition. TPR increments, that does not mean the blood flow will stop completely. That does not happen. Okay, TPR increase is not that much severe that it will stop blood flow. There will be a little decrease in blood flow, but it will be there. Okay, but whenever TPR increases, diastolic blood pressure has to increase. Thank you so much. Okay, so I hope all of you understood this. Okay, now so this is the basic thing that you have to read about the cardiovascular changes during exercise, and I am telling you has been given in Guyton, Genong, everywhere. So at any point of time they can ask you question from here. Now next topic is also related to exercise, but exercise along with respiration. Look at the question, more tricky question, more important question. Change in ventilation during exercise is graphically shown here. Ventilation increases abruptly with the onset of exercise, followed by a brief pause and then more gradual increase. Means typical description of this graph has been given here. So, this is the resting condition, no exercise, then a rapid increase, then pause, then gradual increase. This is the typical thing, right? And they are asking what is the cause of this rapid increase of respiration during onset of exercise. Okay, very good, Dr. Jiten, Avantika, all of you are doing great. Okay, all of you are reading in correct direction. Okay, so what will happen to all of this parameter? The partial pressure of carbon dioxide, partial pressure of oxygen, lactic acid in the muscles, what will happen to all of these parameter in the blood? They will increase, they will decrease, they will remain same. That way you have to think in this question. Okay. So, feed forward, no, this is not typical feed forward. Okay, I will tell you. So, whenever we start the exercise, I told you that even before the start of exercise, the heart rate increases, even the respiratory rate also increases. That is feed forward, that is the psychic stimulation. But here this phase number 1, okay, here the phase number 1, what they are asking here, this is not before the start of exercise, but this is just after the onset of exercise. So, the person has started the exercise, immediately at the onset of exercise, the respiratory rate is rising. If I ask what is the cause of before the start of exercise, then you can say feed forward psychic stimulation, that is the reason. Yes, that is absolutely a reason. But whenever the person has started the exercise, immediately the respiratory rate is rising. Okay, I will tell you mild to moderate and severe may what will happen, what is the difference. But here the answer will be stimulation of the proprioceptor, right. So, why this increase carbon dioxide, decrease oxygen is not the answer, or lactic acid, why not the answer? Because you know, if your basic knowledge in physiology is very strong, then you will start thinking in this way that the ventilation is increasing. What is the cause of increased ventilation? Your respiratory center has to be stimulated, and how your respiratory center will be stimulated? There are peripheral chemoreceptor. Peripheral chemoreceptor, where they are located? The carotid, okay, carotid bodies and aortic bodies, right. These are the peripheral chemoreceptor. So, if you stimulate this carotid body and aortic body, then the ventilation respiratory center will be stimulated and ventilation will rise. Now, if I ask you, any one of you, that what is the stimulation for this carotid body or aortic body, what is the stimulation for peripheral chemoreceptor, all of you can immediately give me answer that sir, hypoxia, that is decrease in partial pressure of oxygen, increase carbon dioxide, okay, or increase H plus ion acidosis. These are the three stimulus for stimulation of the peripheral chemoreceptor. And I hope all of you know that peripheral chemoreceptor, that is the carotid body and aortic body, they contain a glomus cell, GLOMUS, glomus cell type 1, that has been asked in MCQ. The glomus cell type 1 is stimulated by all these three parameters, and whenever you stimulate the glomus cell or chemoreceptor, your ventilation will rise, rate and depth both will increase. But whenever I am saying PO2, I am talking about partial pressure of oxygen of arterial blood or venous blood. Means what is the stimulus for peripheral chemoreceptor? Arterial blood parameter changes or venous blood or both? Could you answer? If there is increase in partial pressure of carbon dioxide in the venous blood, can it stimulate peripheral chemoreceptor? Okay. Answer is no. So, whenever you are writing this, you have to be 100% sure that if there is decrease in partial pressure of oxygen in arterial blood small a, or increase in partial pressure of carbon dioxide in arterial blood small a, or increase in H plus ion in arterial blood acidosis, then and then only it is going to stimulate the peripheral chemoreceptor, not the venous blood composition change, because glomus cell is there inside the carotid body and aortic body, and glomus cell is perfused by which blood? Arterial blood. So, if there is change in the venous blood is not going to perfuse the glomus cell and it is not going to stimulate it, right. So, please remember that there has to be change in arterial blood composition in the form of hypoxia, hypercapnia or acidosis, and then it will stimulate the peripheral chemoreceptor. Now, let us see what happens during exercise. So, suppose this is my muscle which is doing the exercise, this is the muscle which is doing the exercise, and this is my arterial blood, this is my arterial system, and this is my venous system, this is my venous system, right. So, this venous system is taking the blood at the level of lung. So, this is the alveoli at the level of lung, right. Simplified schematic diagram, I hope all of you have understood. Whenever the muscle is doing exercise, we can easily understand that the muscle is going to take more oxygen from the arterial blood. Yes, correct. So, it is taking more oxygen from the arterial blood and it is giving more carbon dioxide to the venous blood, obviously agreed. So, if you take or extract more oxygen from arterial blood, what is going to happen to the partial pressure of oxygen in the venous blood? Decrease, but we write it right PVO2, V stands for venous blood partial pressure of oxygen. What will happen to the partial pressure of carbon dioxide in the venous blood? Obviously, it is going to rise in the venous blood. What will happen to the H plus ion concentration in the venous blood? H plus ion will also increase, but can any of them stimulate your peripheral chemoreceptor? Answer is no. Now, let us see, when this venous blood is reaching at the level of lung, okay. What is the condition of the lung? When the person is doing exercise, lung is doing the hyperventilation, ventilation is increased because of the proprioception and all. So, increased ventilation, what is the meaning of that? Increased ventilation means the lung is taking more fresh oxygen inside it and lung is washing out more carbon dioxide from it. That is the meaning of hyperventilation. So, whatever extra carbon dioxide is coming through this venous blood, that extra carbon dioxide will be easily washed out by the lung, and whatever extra shortage of oxygen has been happened into this venous blood, that will be fully compensated at the level of hyperventilating lung. That means, whatever extra amount of carbon dioxide was there in the venous blood, whatever extra amount of oxygen requirement was there in the venous blood, that will be fully compensated at the level of hyperventilating normal lung, because of which if you look at the arterial blood composition, then you will find out that partial pressure of oxygen is normal, partial pressure of carbon dioxide is also normal, partial pressure of H plus ion, that is the acidosis, this is also normal. So, these are all arterial blood changes. So, when these parameters are normal in the arterial blood, they are never going to stimulate the peripheral chemoreceptor. So, we have to think that during exercise, up to the moderate level of exercise, someone was asking that what is the relationship between moderate and severe. So, up to moderate, if you are doing mild exercise, moderate exercise, up to moderate exercise, there will be no change in partial pressure of oxygen in the arterial blood, no change in partial pressure of carbon dioxide in the arterial blood, no change in acidic condition or pH balance of the arterial blood. So, none of them are stimulus for peripheral chemoreceptor, but the stimulation which is causing increased ventilation, number one is proprioceptor. So, whenever you are moving your joints and muscles, there are proprioceptor, there are muscle spindle, there are Golgi tendon organ, there are muscle joint capsule receptor in and around the joint, all of them will give stimulatory signal to the respiratory center, and that is the main cause of increased ventilation at the onset of exercise. Later on, so you have seen the curve. If I go back to this curve, so this initial part, the rise of ventilation is due to proprioceptors, right. But later on you can find out that there is gradual increase in ventilation when the person is doing exercise for some long time. This increase in ventilation is due to increase in temperature as well as increase in potassium ion into your blood, because we have already seen that oxygen, carbon dioxide, H plus ion, they are absolutely normal. So, who is rising the ventilation later on, because proprioceptor, they are adapting receptor, rapidly adapting receptor. So, after some point of time the proprioceptor is not going to give stimulation, they will be adapted. So, who is going to giving stimulation for increased ventilation later on in the part of exercise? That is increase in body temperature and increase in potassium ion. The potassium will be released from the exercising muscles. Now, how these two are stimulating the ventilation, that is not clear till date according to Genau. How this temperature or potassium is rising the ventilation, this is not clear, but chemoreceptor is not stimulated by oxygen, carbon dioxide or H plus ion. So, what is my bottom line? My bottom line is that during second phase of increased ventilation, this is due to increase in temperature of the body and increase in potassium ion of the body. So, this is complete explanation what happens to the ventilation during moderate grade of exercise, up to moderate grade. Now, when the person is doing severe exercise, right, severe, in this condition lactic acid accumulation will be very, very high into the blood, and in these cases H plus ion is a stimulus for peripheral chemoreceptor. Not only that, whenever there is production of lactic acid, acid will be buffered by bicarbonate ion. Whenever acid is reacting with bicarbonate, it will also produce extra carbon dioxide. So, in these cases the lactic acid will be buffered and it will produce extra carbon dioxide. So, H plus ion and carbon dioxide are the additional stimulation for ventilation during which kind of exercise? Severe exercise. Am I clear? So, that time this temperature, potassium ion will also be there, but additionally if the person is doing very severe anaerobic kind of exercise, then lactic acid accumulation is so high that lactic acid will produce extra carbon dioxide, extra H plus ion in the blood, and that is going to stimulate your ventilation, additional stimulation to the ventilation. Now, tell me whether this is absolutely clear to you or not, okay? Because this can be asked at any point in your examination. In Genau, the graph has also been given and the explanation is also been given, okay? Okay. So, proprioceptor are the answer, and if you look back here, if you look back at the question, so this partial pressure of oxygen, carbon dioxide, they remain normal, they remain normal, they remain normal, okay? They are not the stimulus. Fine, very important, telling you, okay? Now, next question. So, this is all about exercise that you have to read from physiology, right? Okay. Now, we are moving on to next question. So, it is a very simple question. Tell me the answer. I will move quickly from here. So, the diffusion of a substances is plotted against concentration gradient in the following graph. Okay? The substance is, very simple question. This kind of question has been asked every time this changes some parameter of the question and it become a new question, right. Sir, is it enough to know about functions of muscle, spindle and Golgi tendon organ for functions? What is the stimulus? How many fibers are there? What are the different types of fibers in muscle spindle and Golgi tendon organ, particularly the muscle spindle, the nuclear bag, nuclear chain fiber, those fiber idea you have to be there, okay. Bag fiber is responsible for what, chain fiber is responsible for what, and what is the innervation, 1A type of fiber or 1B type of fiber, those many things are you have to read for INI-CET for muscle spindle and GTO. Okay, so all of you are absolutely clear. So, here the graph that is given here, this is typical the curve of saturation kinetics, right. So, this is a kind of saturation kinetics, and any kind of transport process which is mediated by carrier protein, any kind of transport process which is mediated by carrier protein will follow this kind of kinetics, right. So, if I look at the substances, carbon dioxide, oxygen, sodium. So, sodium penetrate the cell membrane through channels, and carbon dioxide, oxygen, no channels are required, but all of them, whether it is mediated by channels or not, they are the part of the simple diffusion, they are the part of the simple diffusion, right. And all of us know that simple diffusion curve is a straight line curve like this. So, this is the typical curve of simple diffusion, but here carrier protein mediated diffusion, and we all know that is nothing but facilitated diffusion, and we all know that the glucose transport can occur by secondary active transport also or facilitated diffusion also. I hope all of you know that the GLUT that we talk about for glucose transport, this is nothing but facilitated diffusion, right, and the SGLT we talk about, they are the part of the secondary active transport, secondary active transport. So, both of them will follow this kind of kinetics, saturation kinetics, but here glucose is the very simple answer here. Okay. Now, please all of you read different types of SGLT and GLUT. Particularly, I am telling you that what SGLT is present in different parts of nephron. Okay. And for GLUT, you will read at least about GLUT 1, where they are dominantly located, GLUT 3 and GLUT 5. These 3 GLUT at least must know, and I hope all of you know that this GLUT 4 is the insulin dependent GLUT, that you all know, but additionally at least GLUT 1, GLUT 3 and GLUT 5, where they are located, please look at once. Okay. That is also important, sometimes question can be given. Okay. Very good. So, all of you have answered correctly here. So, I am going on to the next question. So, now next question is again a very familiar question to you. This kind of question has been asked in INI-CET as well as NEET PG also. Okay. Look at the question and try to answer. So, in the diagram, which level line best illustrates the change in RMP of a neuron resulting from a two-fold decrease in extracellular potassium? So, they are basically asking you what will happen to RMP during hypokalemic condition. That is your question. Okay. Hypokalemia, right? Let us see, bolo. A, B, C, D, E. So, Dr. Ankit, okay, Goshalla, Titir, Jiten, okay, right, great. So, R, what are B, E, okay, B you are asking. So, whenever in physio you look at the curve, na, I told you repeatedly, please look at the x axis, y axis first. Okay. So, y axis, if you look at the voltage that is given, this is EM, EM is the membrane potential, okay, that is the RMP, okay, and then here it is 0 millivolt, 0, okay. During action potential can cross 0 millivolt, it can go up to plus 35, that I can believe, but up to 0 millivolt rise of RMP because of potassium change, that is never going to happen. Okay. So, you can easily exclude this A and B, ये होगा ही नहीं. Okay. अब बाकी में देखो, okay, but अभी D होगा कि C होगा कि होगा, now you have to look at. Okay. Now, what concept I require here? Okay. Yes, so what concept you require here? RMP in mammalian cell is mainly due to which ion? First you tell me. RMP is mainly due to which ion? This is another MCQ which has been asked in all types of examination. Suppose this is a cell, okay. RMP is mainly due to which ion? So, you know ki any cell, no my dear, yes, sodium is for action potential, yes, RMP is mainly due to potassium ion followed by, okay, chloride ion followed by sodium ion. So, the main role for the RMP generation is potassium. Why? Because in resting cell membrane, okay, cell membrane is permeable for potassium ion maximally. Okay. So, what I am saying, suppose this is a resting cell. In this resting cell, when the cell is not getting any stimulus, that is a resting cell, which ion channels are open? The ion channels which opens in resting condition of the cell, resting membrane potential. So, resting condition, the ion channels which remain open, they are known as leak channel, leak channel. Okay. And leak channel number maximum in cell is which leak channel? That is the potassium leak channel is maximum, followed by chloride, followed by sodium. That is why whenever the cell is in resting condition, if I ask you which ion has maximum permeability, your answer is potassium, sir, resting condition. But if I ask you when the cell is generating action potential, which ion is mainly permeable or which ion permeability is maximum during neuron? Sodium. Getting my point? But resting condition means sodium channels numbers are very less. The sodium channel that we talk about during action potential, they are the voltage gated sodium channel. But for resting membrane potential, voltage gated channels are not responsible. It is a leak channel. Leak channel means the channel is always open. They are always leaking. Okay. That is why the channel is known as a leak channel. Now, maximum number of leak channel that is present on resting cell membrane is potassium in all types of mammalian cell. Okay. And we also know that which ion concentration is maximum inside the intracellular fluid? Potassium, 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 and potassium is less in outside fluid, that we know. Okay. So, suppose this leak channel which are present here on the cell membrane, this is dedicated for potassium, okay, and inside the cell which ions are maximum? Potassium, that is a positive ion. I hope all of you know that total amount of positive charge is same with the total amount of negative charge in the intracellular fluid as well as in the extracellular fluid. Means if there is one molecule of potassium, there will be another molecule of negative charge ion along with it. What negative ion? That is least important. It may be chloride, it may be any other anions, but they are not permeable to cell. That is why I am not writing. I am writing potassium positive ion. It is making a couple with another negative ion and it is electroneutral compartment. But the leak potassium channel is present on the cell membrane. So, what will happen? This potassium will try to leak through this channel to the outside environment. Why the potassium is trying to leak? Because potassium will see that there is an open gate in front of me and my concentration is high inside and outside concentration is less. So, the potassium will try to pass through this channel. Okay. But I told you they are making a couple. Potassium is making a couple with another ion. So, obviously, when you are going to travel from one country to other country, you will always try to take your couple part also. So, potassium is traveling along with this anion, both of them are reaching to this channel. Okay. This channel is like a immigration system. Now, he will look at the channel will look at the passport of both the positive ion and anion, but potassium ko chhod dega because potassium has the passport to penetrate through this channel, but this immigration system will not release the anion. So, the anion will stay back here. So, more and more potassium is leaking out of this channel, more and more anion is going to be deposited inside the cell membrane. So, the extra potassium which is traveling outside the cell membrane, that will generate a positive charge outside the cell membrane and the negative charge inside the cell membrane, and this potential difference is nothing but your resting membrane potential. That is why we say that diffusion of potassium through the leak channel is mainly responsible for generation of the RMP. Okay? At least you remember this much of concept. Now, you look at when there is a hyperkalemia. First, we will look at the hyperkalemia. Hyperkalemia, pathological hyperkalemia. So, this is the same cell, okay, and this is the same leak channel. Okay, this is the same cell, this is the same leak channel. Okay, but outside potassium concentration is pathologically high. Now, you tell me the leakiness of the potassium through this channel will be more or will be less. Obviously, potassium concentration was very high inside the cell, that is why potassium was leaking, but now due to some pathology outside potassium concentration is high. So, what will happen? This leakiness of the potassium through the leak channel will be reduced means less number of potassium will go outside the cell, means more number of potassium will stay back inside the cell. More number of potassium means more positive charge will stay back inside the cell. A new equilibrium will develop, a new RMP will develop. When the RMP will moves towards depolarization site, the RMP will moves towards depolarization site, or you can say more positive, right. So, getting my point, whenever there is hyperkalemia, RMP will moves towards the positive side, there will be gradual depolarization of the resting membrane potential. And what will happen in case of hypokalemia? That is our question. In case of hypokalemia, the opposite thing will happen. This is the cell. So, outside potassium concentration is very low. Whenever outside potassium concentration is very low, more amount of potassium will go out of the cell. More amount of potassium means more positive charge is leaving from the cell. So, there will be more generation of negativity inside the cell. We call that this is hyperpolarization. So, this is a kind of hyperpolarization of the cell membrane, or more negative kind of cell membrane. Getting my point? So, please note down, hypokalemia means there will be hyperpolarization, and hyperkalemia means there will be depolarization. So, if I go back to this question, okay. So, here they are asking about hypokalemia. So, more potassium will go out of the cell, means loss of more positive charge. So, there will be negativity inside the cell, negativity means hyperpolarization. If your D is the resting membrane potential, so this D is the RMP, this D is the RMP, I can find out that this E is the hyperpolarization. So, this is going to happen in case of hypokalemia. This is going to happen in case of hypokalemia, and whenever there is hyperkalemia, so this C is going to happen. So, this C in case of hyperkalemia. All of you tell me whether you got it or not. Okay. So, this is the answer. In this question the answer will be E, but if the opposite is asked, that hyperkalemia, what will happen to the RMP? RMP will be C. Okay. Why not B and A? I told you already that hyperkalemia can never increase the RMP up to the level of 0. Not only 0, it can never rise up to more than 10 millivolt. Okay. So, this A and B is never going to be my answer. Only C is possible in case of hyperkalemia, and E is in case of hypokalemia. All of you look at and please tell me whether you get it or not. No. So, you are asking how this increased concentration of intracellular potassium is maintained, sir. You know, this leakiness of potassium is according to number, they are very minute in number, very minute in number, and whatever is leaking, that will be again reversed back by sodium, potassium, ATPase pump are there, and other channels of pump are also there. Na? So, they are going to reverse this thing. Okay. But again the RMP generation is because of the leakiness of potassium, and the number whatever is there inside the cell, in comparison to those number, the leaking amount of potassium is very minute, but still it will develop very minute amount of charge. That is why it is in millivolt. Okay. But according to the total number of potassium which is there inside the cell, that is very huge, right. Which is more dangerous? Okay, you tell me which is more dangerous. So, this one is more dangerous, hyperkalemia is more dangerous, because whenever there is depolarization, you may thinking that depolarization is good for cell membrane because it is easily going to generate action potential, but no. If there is persistent depolarization, they are going to inactivate voltage gated sodium channel. Persistent depolarization, if it is happened during hyperkalemia, what will happen? That depolarization is going to inactivate voltage gated sodium channel, NAV, and if you inactivate voltage gated sodium channel, what is going to happen, my boy? Okay. Voltage gated sodium channel is responsible for action potential generation on heart as well as neuron. So, action potential will stop in the heart will not be able to contract, because after action potential heart contraction start hota hai. So, heart will stop in diastole, that is the most dangerous condition. Okay. But in case of hyperpolarization, excitability will be reduced of the cell membrane, excitability will be reduced in the heart also, but not much dangerous like that of the hyperkalemic condition. ठीक है. In what condition it will be C? I told you C will be seen in case of hyperkalemic condition, hyperkalemic, because what is C? C is, okay, so please, very good question. So, if you look at C, C is more positive. Yes, C is more positive than RMP. So, more positive than RMP means depolarization. Okay. Gradual depolarization of the resting membrane potential will be seen if there is hyperkalemia. So, hyperkalemia pathology hoga to C is the answer, right, and hypokalemia hoga to E is the answer from this question. Clear all of you? Okay. I hope this is clear. Next question. So, next question is very easy. Okay. Now, this is the action potential. Okay. So, all of you please tell me the answer, correct answer of this question. So, I will move on to the next question quickly. Very good. Thank you for giving thumbs up. So, that means you understood. Very good. So, I will wait for some more answer. If I get more correct answer, then I will understand this is clear to all of you. Yeah, very good. Go on. Right. Okay. So, by this time, okay, when INI-CET is just waiting or just knocking on your door, I hope all of you know that what is the meaning of this curve. So, this red color line that I am highlighting here, this is the action potential, this red color line. Okay. So, this part, this is known as the after hyperpolarization. I hope all of you know that this is known as after hyperpolarization phase, right. Okay. Thank you, right. So, after hyperpolarization, and we all know that during action potential. So, if this is my action potential like this, okay, if this is my action potential like this, we all know that both sodium channel and potassium channel, they start opening from the beginning point of the action potential, means this sodium channel, it will also start opening from the same point, and the potassium channel, suppose this is a green color, this will also start opening from the same point. But this sodium channel, which is responsible for action potential, this is voltage gated sodium channel, this is, okay, I should use the yellow color here. Okay. So, the sodium curve, this is voltage gated sodium channel, this is very fast in nature, and this potassium channel, that is also a voltage gated potassium channel, this is very slow in nature. So, if you look at the opening up of the sodium channel, it will open up quickly and it will also inactivate quickly like this. Okay. But potassium channel, it will take long time completely or maximum open, then again it will take long time for complete closure. So, this green color curve is typically the potassium permeability और potassium conductance, इसको हम लोग बोलते हैं potassium permeability curve, okay, permeability curve और potassium conductance curve, okay, and this yellow color curve, this is the sodium permeability curve or sodium conductance curve, right. From this diagram, multiple question has been asked that maximum potassium permeability during which phase of action potential, your answer will be here, that maximum potassium is permeable during the middle part of repolarization, and maximum sodium permeability, that is here, maximum sodium permeability is here, maximum sodium is permeable at the peak of action potential. At least you remember this many of information from here. Got it, everybody? So, we are moving on to the next question. I hope this is clear to all of you. Okay, this is the basic minimum about action potential. Okay. Okay, next question is here. Now, I will say that this is one of the difficult most question in this session. Okay, and the diagram is taken from Genong textbook of medical physiology. So, you cannot ignore, it is a new question, but you cannot ignore this kind of diagram in particularly INI-CET kind of examination. Any point of time they will ask question from here. So, read the question, try to understand and try to answer, difficult one, okay, but try to understand. Okay. First, you clear up which graph is from presynaptic neuron, which graph is from postsynaptic neuron, and then you read the question. Okay. So, presynaptic, presynaptic, postsynaptic. So, there is a long description. Okay, I will make you understand that what is the description. Okay, and then you will try to look back at the question once again. Okay, because if you look at the statement, it may looks that it's a difficult, sir, I am not understanding. So, let us start understanding what is they are asking here. Okay. So, you know that in central nervous system there are two major type of synapse, one is the excitatory and one is the inhibitory, right. Okay. So, first of all, suppose I am drawing one excitatory synapse between two neurons. So, this is my presynaptic neuron, right, and this is my postsynaptic neuron, right, and this is an excitatory synapse. So, most probably we can understand that the neurotransmitter which is present in this presynaptic neuron is glutamate. Okay. Now, all of you know that what is the mechanism of release of neurotransmitter from the presynaptic neuron. Yes, you know. Yes. So, what is that? So, if you look at the mechanism, all of you know that first there will be an action potential which is traveling down this neuron. Okay. So, this action potential, okay, just hold on. So, this action potential is traveling down the neuron. Okay. Then this action potential is going to causes depolarization of this presynaptic membrane. Okay. Whenever there is depolarization of this presynaptic membrane, there will be opening of voltage gated calcium channel here. There will be opening of voltage gated calcium channel here, through which calcium will enter, and that calcium is going to release this neurotransmitter from the presynaptic neuron. That is the simplest mechanism that you know. Okay. And it will be taught in the pharmacology also as well as physiology also. Okay, you know that. And this kind of mechanism is also there in the neuromuscular junction. So, you must know this thing. Okay. And then when the glutamate is released from the presynaptic neuron, it is going to act on the postsynaptic receptor here, and there are various types of glutamate receptor, NMDA, AMPA, kainate, you know this name. Okay. And all these receptor they are permeable for some ions, means if you stimulate this receptor, if the glutamate is attaching with the receptor, through this receptor some ions will enter, mostly the calcium or sodium, they will going to enter through this channel. Okay. So, whenever calcium or sodium is entering in the postsynaptic neuron, what will happen to the RMP of the postsynaptic neuron? So, normally RMP means inside is negative, outside is positive. Now, there is entry of positive ion in the form of calcium and sodium. So, I can understand that the resting membrane potential of the postsynaptic membrane will gradually increase towards positivity direction, positive direction. So, this positive potential which is generating in the postsynaptic membrane, okay, if it is above the threshold voltage, if it is above the threshold voltage, what will happen? It will open up huge number of voltage gated sodium channel opening. It will lead to huge number of voltage gated sodium channel opening. Getting my point? So, whenever it is above threshold, it will open up huge number of voltage gated sodium channel, and through this channel huge amount of sodium will enter inside the cell. Those sodium will increase the membrane potential to plus 35 millivolt, and this is nothing but action potential generation on postsynaptic membrane. Getting my point? That means this opening up of voltage gated sodium channel will leads to action potential generation. So, I can understand one important thing here, that this potential, this positive potential which is generated on the postsynaptic membrane, right, it is capable of generating action potential, means it is a kind of excitatory potential E, and this excitatory potential is generated at which part of the synaptic membrane? It is generated at the level of postsynaptic membrane. That is why this potential is known as EPSP, excitatory postsynaptic potential. So, if I ask you what is the ionic basis of excitatory postsynaptic potential, easily you can say that, sir, it may be calcium ion or maybe sodium ion or can be both. Okay. And what kind of potential the EPSP? EPSP is a kind of local potential, means this potential cannot travel down through the whole neuron, but it can generate action potential via opening up of the voltage gated sodium channel, right? Okay, got it. Now मेरे को मूड हुआ that I want to measure this potential. Okay, so suppose I am a scientist. Okay, my mood is very good today. I want to measure all this potential from the presynaptic neuron, postsynaptic neuron. So, what I will do? Okay, if you want to measure this potential, you have to put one electrode in the presynaptic neuron and you have to put one electrode in the postsynaptic neuron also. So, I have put electrode inside the presynaptic neuron and I have also put 2 electrode inside the postsynaptic membrane. What I am recording? I am recording from the presynaptic membrane, I am recording the action potential because action potential is coming first. So, I am recording that. Okay. So, I have recorded the action potential from this presynaptic neuron. Along with the action potential, I have also measured how much calcium is entering in the neuron. Entering means it is a downward direction. Getting my point? These 2 curve are you getting? So, this red color curve that I have recorded from the presynaptic membrane, this is the action potential, and this white color curve, this is the influx of calcium in, that is why it is in inward direction. Okay. These 2 curve I have plotted from presynaptic membrane. Now, from the postsynaptic membrane, I have recorded this EPSP. EPSP is a kind of positive potential or negative potential. All of you know that EPSP is a positive potential, depolarization. So, if this is your curve, in this diagram EPSP will look like this. So, this is nothing but EPSP, this kind of curve I have recorded from postsynaptic membrane. Now, you look at this curve, this is the diagram which has been given in the question. So, this presynaptic potential पहले देख लेते हैं. So, this is the presynaptic potential, this is the presynaptic potential. What you have plotted? You have plotted this action potential, this red one, okay, and you have also plotted this calcium influx, okay, that is also red. That is the control condition, original condition. And from the postsynaptic membrane, what you have recorded? From the postsynaptic membrane, you have recorded this curve. This is nothing but positive voltage, this is red color curve, this is nothing but EPSP. So, that is why EPSP is recorded from postsynaptic potential, right. Now, we know that this synapse can be inhibited by a presynaptic neuron. What is the meaning? Meaning, okay, so if I delete here, look at here. So, suppose I want to inhibit this synapse by a presynaptic neuron. So, I am drawing a presynaptic neuron here. So, this is an axon terminal. This is an axon terminal which is inhibitory in nature. So, this axon is inhibitory in nature. This inhibitory axon is making a synapse on the presynaptic neuron. So, this is the presynaptic neuron, it is making a synapse onto that. So, what kind of synapse this is? This is one axon, and this yellow color neuron, this is another axon. So, synapse between 2 axons, we say that this is a kind of axonic kind of synapse. This axonic synapse causes presynaptic inhibition, because now this neuron which is inhibitory in nature, it is going to inhibit the presynaptic neuron. How it is going to inhibit? So, look at this yellow color neuron. Okay. So, this yellow color neuron, it is making a synapse with this deep yellow color neuron, this is the presynaptic neuron. Okay. So, this is my presynaptic neuron, I hope you are understanding, and this is one extra neuron, or you can say third neuron which is inhibitory in nature, right. This is third neuron which is inhibitory in nature. Now, inhibitory in nature means the neurotransmitter, most probably this is GABA. Okay. Now, whenever the GABA is released from the presynaptic terminal, okay, it is going to act on this membrane. Okay. And what is the receptor for GABA? GABA, what is the receptor for that? Receptor for GABA is GABA A or GABA B receptor. If it is GABA A receptor, which ion is going to enter on the presynaptic neuron? Sorry, very sorry. Which ion is going to enter? That is the chloride ion. And if it is GABA B receptor, all of you know that GABA B open a potassium channel. So, potassium will go out of the cell. So, yes, GABA A is chloride entry and GABA B is opening up of the potassium channel, but in both the cases, whether it is GABA A chloride is entering or GABA B receptor potassium is going out of the cell, in both the cases there will be more and more negativity of the presynaptic cell membrane, more and more negativity of the presynaptic cell membrane. Getting my point? Because loss of potassium means loss of positive charge and entry of chloride means entering of negative charge. So, in both the cases there will be hyperpolarization of the presynaptic membrane or presynaptic neuron. Now, if there is hyperpolarization of the presynaptic neuron, so this neuron rather than getting this positive charge, now it is getting negative charge, more and more negative charge. Okay. So, tell me, rather than getting positive charge, this presynaptic neuron is getting negative charge because of the presence of this axo-axonic synapse. So, what will happen to the amplitude of this action potential? If this is the normal amplitude, I can easily understand that the amplitude of the action potential will be reduced. Getting my point? If there is more and more negativity, do you think this calcium channel is going to open up to 100% level? Answer is no, because calcium channel is voltage gated channel, and what kind of voltage you require? Depolarizing voltage you require, not the negative voltage, not the hyperpolarizing. So, what will happen to the calcium influx? The calcium influx will also decrease. So, now you look at this presynaptic curve. So, if you look at this curve, now you look at the broken line here. Now, you look at the broken line. Okay. So, I will delete this. So, if I look at the broken line, I can easily understand that the amplitude of this action potential has been reduced and the influx of calcium has also reduced. Okay. And if your calcium influx is low, so what will happen to the neurotransmitter released from the presynaptic neuron? Less. If the neurotransmitter is less, what will happen to the EPSP amplitude? It will also decrease. That is why I can also find out that this EPSP amplitude has been reduced. Now, you are getting me. You tell me whether you are getting this or not. Everybody, please tell me whether you get this curve or not. Okay. This curve is a little difficult, but please look at and tell me whether you get this thing or not. So, if there is a kind of inhibitory synapse, okay, this is known as presynaptic inhibition. The inhibition is occurring from presynaptic neuron level. That is why this is known as the presynaptic inhibition. So, if you look at here, this inhibition is occurring from the presynaptic neuron. That is why this is known as the presynaptic inhibition. And in case of presynaptic inhibition, what kind of synapse is there? In case of presynaptic inhibition, the axo-axonic type of synapse is there, right. So, if there is presynaptic inhibition, calcium influx in the presynaptic neuron will be reduced, neurotransmitter release will also reduced, and in the postsynaptic membrane, EPSP amplitude will be reduced. Okay. Now, we will go back to the MCQ. So, now the MCQ is saying identify the false statement about the dashed line. Okay. So, dashed line is showing that there is reduced amplitude of the EPSP, reduced amplitude of the action potential and reduced calcium influx. So, first statement produced due to enhanced calcium entry in the presynaptic neuron. So, आपका false हो गया. Okay. Can be produced by opening up of voltage gated potassium channel. It is true, because if it is stimulating the GABA B receptor, then potassium channel will open up. Okay. Then effect can be produced by GABA, absolutely true. Okay. It can also be produced by glycine, but it can be produced by GABA. Presynaptic neuron is releasing GABA. This dash line is produced due to increased chloride conductance. This is also true if the receptor is GABA A receptor. Got my point? So, the answer of this question is A here. Okay. Tell me whether you get it or not. Okay. Answer is clear cut A, right. Okay. So, please be careful, this kind of question can be given. So, this is typical of presynaptic inhibition, and sometimes we say that rather than presynaptic inhibition, there is presynaptic facilitations is also there. Presynaptic facilitations is also there. So, if you compare this curve with the previous curve, what you are finding out here? You are finding out that the broken line has increased amplitude. okay, means EPSP amplitude has been increased here. Okay. Broken line is showing that calcium entry is more, okay, means increased calcium influx into the presynaptic membrane, right. Broken line is also showing that amplitude or the action potential is persisting for some long duration. So, this is typically known as the presynaptic facilitations, okay, means if this is a synapse between two neuron, there is a third neuron which is excitatory in nature, and this synapse is known as the presynaptic facilitations. Very good. Presynaptic facilitation is done by the neurotransmitter serotonin. Okay? Serotonin. It acts on its receptor and increases the CAMP level inside the cell. That CMP causes phosphorylations of the channel, and that increases influx of positive ion inside the cell. Okay? That is why the presynaptic facilitations. Okay? So, serotonin presynaptic facilitations typically seen in case of memory forming synapse. The synapse which are responsible for memory formation, there this kind of synapse is there, and the neurotransmitter is serotonin. Okay? It will act on its receptor, it will causes increased CMP inside the cell, that will causes phosphorylation of channel, the channel will open up and more positive ion will enter in the cell. Got it? So, this is about presynaptic facilitations. Okay? Rather than entry of positive ion, it can also cause a decreased potassium efflux from the cell, that is also a reason of presynaptic facilitations, right, Dr. Titir and all? Yes. Okay. Memory forming synapse in the at the level of hippocampus as well as some cerebellar synapse, right. Actually, this is done in C. Snell. The experiment has been done on C. Snell, and the scientist has proven that during memory formation, some of the positive synapse is showing presynaptic facilitations, and that causes the consolidation of the memory, right. But it is also seen in our brain, particularly the hippocampus and cerebellar cortex level. Got it? Okay. Now, next question. Next question again from a basic understanding. Okay. There are 4 laws of specific law of sensory physiology has been given here. Law of specific nerve energetic, level 9 principle, frequency coding principle, law of projections. Okay. You have to identify from the diagram that which law is shown here. If you look at the action potential, okay, amplitude of the action potential is not changing. Okay. You are giving more and more stimulation, but action potential amplitude is not changing. Which law this is? It is not written here. I am asking another question. Okay. So, look at what is this question? The question is action potential in an afferent fiber from a mechanoreceptor, okay, in response to pressure stimulus. Okay. So, you are giving more and more pressure on your skin. Okay. So, this lower part of the curve, it is recording the pressure. First, pressure is below 60 millimeter of mercury. Look at this curve first. Okay. Look at this curve first. What is this? This is nothing but pressure. Okay. So, this green color line is showing that first you giving a pressure which is below 60 millimeter of mercury. So, this is pressure. Okay. No action potential you are getting. Then you are rising the pressure to 60 millimeter of mercury. You are getting action potential. You are giving more pressure here, more pressure, more than 60 millimeter of mercury pressure. You are getting action potential, but you are getting action potential in a more frequent manner, means the frequency of the action potential has been increased. I have given more pressure here. Okay. Again the action potential, amplitude is same, but increase in more frequency, right. So, even if you just understand this portion, you are going to give me the answer that sir, this is something related to frequency, and the answer will be frequency coding principle or C. This is known as the frequency coding principle, but try to understand. If I only ask that which phenomena has been shown by this diagram, that whenever you are giving more amplitude of stimulus, your action potential frequency is rising, but amplitude is not changing. What law this is? This is known as the all or none law. This is known as the all or none law. What the all or none law is saying? all or null law is saying that if your stimulus is more than threshold, then action potential will be generated, and if it is below threshold, action potential will be not generated. So, if you look at the first stimulus, this is the stimulus, first stimulus, is it generating any action potential? Answer is no. So, this is inadequate stimulus, inadequate stimulus. Are you getting any action potential? No. But whenever your stimulus is adequate, so all of them are adequate stimulus, all of them are producing action potential, but are you getting any increase in amplitude of the action potential? Answer is no, sir. So, this is typical of all or null law. But here in the option all or null law is not given, otherwise you can also mark all or null law. But here the phenomena that is showing, it is typically taken from Genong, and this is the actual diagram. Look at the diagram once again, you will understand in a better manner. So, what is here? You are finding out that there is a glass probe, okay, like this Apple pencil. Okay. So, there is a glass probe which is pressing over your skin, and during this pressing I am measuring what is the pressure I am giving onto your skin, right. Okay. So, you are basically giving some indentation on the skin. See, more and more pressure you give, more and more indentation you are creating on the skin, right. So, this indentation means the mechanoreceptor which are present just below your skin, it may be Pacinian corpuscle, it may be Misner's, Merkel's, any receptor, they are going to be deformed, mechanically deformed. That is why we say that it is going to stimulate mechanoreceptor. Okay. So, the first stimulus which you are giving here, it is not producing any action potential. So, are you going to perceive this touch? Answer is no. So, here I am going to perceive no touch sensation, no perception of touch. Getting my point? Okay. Now, you are giving more stronger touch, more strong pressure on skin. So, I am going to perceive here, perception will start from here because of starting of action potential. Okay. Now, if I give more and more pressure of the skin, more and more pressure on the skin, how the brain will understand that the touch on your skin is light touch or crude touch? How the brain will understand? Because what is reaching onto your brain? Only the action potential. And is there any change in action potential amplitude? Answer is no. So, whatever is going to brain is only and only action potential. If you give more and more stimulus, more and more strong stimulus, amplitude is not changing, but only parameter of action potential that is changing is frequency. That is why we say more stronger the stimulus, more will be the increase in amplitude of the action, more increase in frequency of the action potential, and more is the frequency of action potential, more strong perception will be seen at the level of brain. Getting my point? So, इसलिए we say that increase in strength of stimulus, increase in strength of stimulus increases the frequency of action potential. Increase in frequency means increase in perception at the level of brain. This is nothing but frequency coding principle of our nervous system. By this way, our nervous system understand that the stimulus which is coming from your periphery, whether that is light stimulus or crude stimulus, more pain or less pain, more touch or less touch, by assessing the action potential frequency. Getting my point? Because amplitude is not going to change, because it follows all or null law. Am I clear to all of you? Am I clear to all of you? So, I hope all of you have got it, that why the answer is frequency coding principle, right? Why the answer is frequency coding principle. Just give me thumbs up whether you got it or not. Okay, I will move on to the other laws. So, other law which has been written here, specific nerve energetic, level 9 principle, law of projection, they are also important for INI-CET type of examination. Okay, look at, I have written here the about other law. Law of specific nerve energetic, first law. Remember like this, that from your periphery up to the level of your brain, there are different nerve fiber, there are different pathway, ascending pathway we say. So, suppose this is from the level of your skin, okay. From the skin, one pathway is going to brain, this is the first order neuron, this is the second order neuron, third order neuron, it is going to the level of brain. If this pathway is attached to the portion of brain which is perceiving pain, okay. Suppose this pathway, this fiber is connected to a particular portion of the brain, to the particular portion of the somatosensory cortex or thalamus, whatever you say, and that is responsible for pain perception. Then whether you stimulate at the level of skin or whether you stimulate here or here or here, okay, wherever you stimulate along the pathway, the sensation that you are going to perceive is only and only pain. Means the perception depends on the part of the brain that is going to be stimulated, right, getting my point. So, touch fiber will attach to a different part of the brain which is responsible for perception of touch. This has been generated from the point of evolution, right. That small part of the brain, it is responsible for touch perception. If you connect another fiber, pain fiber, to the touch pathway and you stimulate the pain fiber, again the perception will be touch perception only, because ultimate perception depends on the part of the brain which is going to be stimulated ultimately. So, that is known as the law of specific nerve energetics, right. Second is the level line principle. This is very simple. Level line principle means each and every sensory pathway, they travel through a particular region of spinal cord, particular region of brain. All of you know that if you take the cross section of the spinal cord, okay, so this is not the ideal cross section, but if you take a cross section of the spinal cord, dorsal column pathway, they have a particular pathway, right. You know that cervical fiber will be from here, then thoracic fiber, then lumbar fiber, then sacral fiber, okay, means from lateral to medial, these are the fibers. So, every pathway from a particular part of the body, they are traveling through a specific region of the central nervous system, that is known as the level line theory, just like the hardware system of the computer, right. So, that is the level line principle. Third law is the law of projection. This is important for your MCQ. Law of projection is one of the explanation why there will be phantom limb pain sensation, has been asked in AIIMS PG. So, please note down. So, I told you earlier that if this is the pain pathway, this pink color pathway, suppose this is a pain pathway, if you stimulate this pathway at any point, ultimately sensation that you are going to perceive is pain. But the question is, where from the pain will be perceived by the brain? Okay. Brain cannot perceive that the pain is coming from this location. If you stimulate here, brain cannot perceive that the stimulation is from the middle part of the pathway, no. Brain will always perceive as if the pain is coming from the level of receptor. Whether you stimulate here or here or here, brain will perceive pain, but brain will project the pain as if the pain is coming from the level of receptor. Getting my point? So, suppose this is coming from the region of your hand and there is an amputation, okay. So, there is an disturbance of this pathway, amputate, okay. Now, these are the neuronal ending, okay, which will be projected from the amputated limb. If I stimulate here, brain will obviously perceive the pain, but brain will not be able to perceive that it is coming from the cut end of the neuron. Brain will project as if the pain is coming from the receptor, although the receptor is not there, it is already amputated, and that is nothing but projection of pain from the level of receptor, that is nothing but phantom limb pain sensation. Got it, everybody? Tell me whether you got it or not. So, that is the law of projection, okay. So, phantom limb are explained by two things, one is the law of projection and second theory is the cortical plasticity. You just remember this term, cortical plasticity, these two terms explain. So, one is law of projection, one is cortical plasticity, these two are the explanation of the phantom limb sensation, okay. And the fourth law, you have to remember only one thing, that relationship between actual change in physical stimulus and the perception. So, stimulus and perception, relationship between these two. So, if I give a stimulus, how much will be the perception by your brain? Obviously, if I give this kind of pain, I am feeling little pain, but some person may feel a little more pain, some other person feel a little less pain. So, perception is variable from person to person. That is why this is law of psychology, psychophysics बोला जाता है कि how much stimulus you are giving and for that how much perception the brain is perceiving. This law is Weber-Fechner law. Multiple mathematical equations are there, but for the time being, for your exam, you just remember relationship between stimulus strength and perception is Weber-Fechner law. So, at least you remember these four law for your MCQ purpose. Give me a thumbs up whether you get it all this point or not, okay. And if you got it, in depression I cannot comment that, I do not know, I have to check it, okay. Really because I have not gone through that in any book, that whether it is changing in depression or not. I have to check it. You can message me later on, I will got. Okay. So, now we look at the next question. Okay. So, this is very easy question, repeat question of NSPG. If you give me answer, I will go to the next question. Okay. So, second heart sound, how will you understand? Second heart sound is more amplitude or less amplitude. So, second heart sound is a soft heart sound. Soft heart sound means less amplitude. Okay. So, if you look at this, this is more amplitude sound, this is low amplitude sound. But we also have to remember that the first heart sound, yes, okay, second heart sound will appear at which point? Point number C. Very, very good, very, very good. Okay. So, first heart sound, you remember this, first heart sound, it will appear at the peak of R wave in ECG, and second heart sound, it will appear at the end of or at the later half of end of T wave in ECG. Okay. Just remember these two things, okay? Because you know the first heart sound occurred during the phase of contraction, isovolemic contraction, and second heart sound occurred during the phase of relaxation, and contraction means nothing but QRS complex. So, it is related to the QRS complex, and T is the repolarization of the heart. Repolarization ke baad there will be relaxation. So, obviously this is the second heart sound. And how to identify third and fourth heart sound? We know that the fourth heart sound is due to atrium contraction. If it happens, then fourth heart sound is due to atrium contraction. Atrium contraction means you require atrial depolarization. Atrial depolarization means P wave. So, any heart sound, if it is appearing just after the P wave, right. So, if this is your P wave, this heart sound is appearing just after the P wave. So, this is my fourth heart sound, and in between any heart sound that is appearing, that is a third heart sound. So, this is the thing that you have to remember, and I hope all of you know the ECG and the heart sound recording instrument is known as the phonocardiogram. Okay. So, I will pass on to the next question. So, the next question is here, a little difficult question, but try to understand. There is an important core concept here. Change in aortic pressure is recorded with time. Change in aortic pressure is recorded with time, and it is given below. Maximum blood flow of left ventricle will occur at which point? So, just you have to understand from your basic knowledge. Suppose you do not know anything about this. Okay. You know that blood flow to the left ventricular muscle occur during systole of the heart or diastole of the heart. We all know. Okay. We all know that, and that you have to identify from here. Okay. Okay. So, coronary blood flow occur during which phase of cardiac cycle? During systole or during diastole? Okay. For the left ventricle, it is only during diastole. And this curve is the aortic pressure curve. You have to identify which point is the diastolic point. Okay. Which point is the diastolic point? Question is maximum. So, please note down that whenever I will explain this, you will understand that the blood flow to the left ventricular muscle will occur both during B and C, but maximum blood flow will occur during point number B. So, my answer here is point number B. Okay. Now, please look at the explanation, very, very important. Okay. I am telling you. Okay. So, first of all, aortic pressure curve, aortic, very good, pressure curve. Okay. You know that whenever the left ventricle is pumping blood at the level of arch of aorta, okay, if you measure the pressure from the arch of aorta from here, there will be sudden increase in arch of aortic pressure. So, there will be sudden increase in arch of aortic pressure, right, like this, right. So, the ventricle is pumping blood, arch of aortic pressure is rising. So, this wave will be created. Now, when the ejection of the left ventricle is reduced, then the aortic pressure will also start reducing like this. Okay. Suddenly, there will be closure of these semilunar valves. Whenever there is closure of the semilunar valves, after the closure of the semilunar valves, what is going to happen? There will be a little increase in aortic pressure again, and then there will be sudden fall of aortic pressure. Okay. So, why there is increase in pressure? Because you know that when you ejecting blood, whenever you are ejecting blood at the level of arch of aorta was expanding like this, because it contain elastic tissue. Now, when your semilunar valves are closed, this arch of aorta will recoil back. Whenever it is recoiling back, it will put some pressure on the blood which is present here. So, because of this pressure, there will be a positivity in this aortic pressure curve, and we say that this positive wave is known as the dicrotic wave. Okay. And this dicrotic wave is due to elastic recoil of the arch of aorta. And this notch that is created here, this notch indicate that this is the closure point of semilunar valves or aortic valves, and this is known as the dicrotic notch, dicrotic notch. So, now I can understand that in this aortic pressure curve, from this point up to this dicrotic notch point, this is the ejection phase of the ventricle, or I can understand that this is basically the part of the systole of the ventricle. And from this point number and from this dicrotic notch, the remaining part means from here to here, this is nothing but the diastole of the heart. Okay. This is nothing but the diastole of the heart, right. So, during diastole, the blood flow to the coronary vessels will happen, the blood flow to the muscles of the heart will happen, right, but the maximum will happen during this part. Okay. During this part, what is the reason, that I will tell you. So, the blood flow will happen here also, the blood flow can also happen during the phase of C. Okay. Blood flow will also happen here, but the maximum is at the point of B. Getting my point? So, from this curve you have to identify what is the phase of diastole, because coronary blood flow to the left ventricular muscle occurs only during the phase of diastole. Okay. But again and again I am saying that for the left ventricle, for the right ventricle, the coronary blood flow can occur even during systole. What I am saying? I am saying one important thing, okay, and we will understand this curve a little later, but before that look at. So, coronary artery, they originate from the base of the arch of aorta or root of the arch of aorta, you all know. Okay. So, if this is the arch of aorta and left ventricle, all of you know that the coronary vessels, they originate from here, coronary vessels, they originate from here, right. So, coronary artery, they are originating from here. So, if I ask you what is the pressure inside the coronary artery, your answer will be coronary artery pressure, that is nothing but the aortic pressure or the blood pressure, right. Getting my point? So, coronary artery pressure means aortic pressure. Okay. So, coronary artery pressure is the aortic pressure, it is trying to perfuse these muscles of the heart, and this pressure will be opposed by ventricular pressure. Ventricular pressure will oppose this coronary perfusion. Getting my point? So, basically the bottom line is that the perfusion of heart muscles is determined by aortic pressure minus ventricular pressure. Am I clear or not? Ventricular pressure is opposing the coronary artery pressure, and coronary artery pressure is nothing but the aortic pressure. So, coronary artery pressure is nothing but aortic pressure that is trying to perfuse the muscles, but heart is contracting, ventricular pressure is rising, and that is trying to oppose the perfusion pressure. So, I can understand that this aortic pressure is normally how much? Aortic pressure is normally how much? During systole, very important thing, during systole it is approximately 120 millimeter of mercury, and during diastole this is 80 millimeter of mercury, that is the normal aortic pressure. Okay. Now, you have to think of that aortic pressure means this is also the pressure inside the coronary artery during systole and during diastole of the heart. So, during systole what is the pressure inside the coronary artery? 120, during diastole 80. Now, I have to look at what is the pressure inside the ventricle during systole and during diastole. I have to consider both the ventricle. So, now let us look at. So, left ventricle first. During systole, what is the pressure inside the left ventricular chamber during systole? So, left ventricle is contracting, it has to eject blood into the arch of aorta. So, arch of aorta pressure jitna hai, left ventricular pressure has to be little more than that, otherwise it will not be able to eject the blood. So, during systole, left ventricular pressure can go up to 121 millimeter of mercury, means little more than systolic pressure in the arch of aorta. Okay. So, now you look at what is the perfusion pressure, aortic pressure minus ventricular pressure. Aortic pressure is 120, ventricular pressure is 121. So, aortic pressure minus ventricular pressure, if you do, this is minus 1, means minus 1 pressure means, is it going to perfuse the heart muscles? Answer is no. That is why we say that during systole, left ventricular muscles did not get any blood, because all the coronary vessels will be compressed by huge amount of ventricular pressure. Got it? Okay. Now, you think of the diastole. So, this is very simple. During diastole, what is the left ventricular pressure? So, left ventricular pressure goes up to 0 millimeter of mercury, that is the lowest pressure in the left ventricle during diastole. Okay. And this lowest pressure appear during the phase of isovolumic relaxation, at the end of isovolumic relaxation near equal to 0. So, now the ventricular pressure is 0 and your aortic pressure is 80 millimeter of mercury. So, what is the pressure difference? Plus 80. Plus 80 means perfusion of the muscles of the heart is going to happen. That is why we say that in case of left ventricular muscles, left ventricular muscle gets its blood only during the diastole, no blood during the systole. Ventricular wall, ventricular muscles, myocardium. But you think of right ventricle, that is completely different. So, for right ventricle, what is the maximum ventricular pressure during systole? Could you tell me? What is the maximum ventricular pressure in the right ventricle during systole? That is 25 millimeter of mercury. Okay. And for right ventricle, what is the minimum pressure during diastole? That is 0 millimeter of mercury. So, during systole, the pressure inside the ventricular chamber, right ventricle I am talking about, is 25, and aortic pressure is how much? Aortic pressure is 120, means coronary artery pressure is 120. So, what is the pressure difference between coronary artery minus ventricular pressure plus 95? So, do you think the myocardium will be perfused for the right ventricular muscles during the systole? Answer is why not? Positive pressure plus 95. So, it is going to perfuse the right ventricular muscle even during the systole. And what about the during diastole? During diastole, again the pressure difference is plus 80. So, again it is going to perfuse. So, what is the bottom line? Bottom line is that, right ventricle getting perfusion both during systole as well as during diastole, क्योंकि the pressure difference is positive in both the condition. Getting my point? So, please note down that the pressure difference is positive between coronary artery minus ventricular pressure both during systole and diastole. So, right ventricle gets its blood, right ventricular muscle gets its blood both during systole, both during diastole. But if I ask you maximum blood flow to the right ventricular muscles occur during systole or diastole, looking at this number, what can you conclude? Left ventricular muscles perfusion mainly occur during systole or diastole. What is your answer? Looking at this graph, looking at everything, left ventricle muscles gets its blood only and only during diastole. There is no confusion. Left ventricular muscle are perfused only and only during diastole. Systole, no. Right ventricle muscles get its blood during diastole also, during systole also, coronary perfusion. Okay. So, left ventricle is diastole. For right ventricle, more blood will perfuse the coronary muscles, more blood will perfuse the myocardium during systole or during diastole. That is my question. Okay. Look at this curve. So, left coronary artery, okay, left coronary artery, see, if you look at this left coronary artery, so blood flow is hugely rising during the phase of diastole, and during the systole blood flow is stopped. But right coronary artery, see, maximum blood flow during systole and during diastole blood flow is lesser. So, please note down. Okay, no, this is the table which is given in Genong, and if you look at the table, the same thing that I have described, that aortic pressure is this, left ventricular pressure is this, right ventricular pressure is this. So, left ventricle during systole the pressure difference is minus, means no blood flow, okay, and during diastole blood flow is yes. For right ventricle, okay, blood flow is happening during systole also, during diastole also. But if I look at the pressure, maximum blood flow during systole. So, right ventricular muscles maximum perfusion occur during systole, okay, and perfusion occurs both during systole as well as during diastole. But for left ventricular muscles, perfusion only during diastole. Only during diastole. Getting my point? So, if I go back to this curve here, okay, yes, go back to this curve here, you look at. So, left ventricular muscles blood flow, left coronary artery blood flow is maximum during which phase of aortic pressure? You can find out here, just after this dicrotic notch. During this dicrotic wave, the left coronary artery blood flow is peaking, is reaching to a maximum level. But if you follow this right ventricular, okay, right coronary artery blood flow, then you can find out that maximum blood flow is during this phase. This phase is which phase? This is nothing but systolic phase, particularly bologe. So, during reduced ejection phase or slow ejection phase. So, right ventricular muscles get maximum blood flow during reduced ejection phase of systole, okay, but it get its blood both during systole and diastole. But for left ventricle, it gets only its blood flow during diastole. Am I clear? This is a little hard to digest, okay, because the bottom line concept from our MBBS knowledge is that coronary perfusion, ventricular muscle perfusion is only during diastole. There is no perfusion during systole, but that is true for left ventricle. For right ventricular muscle gets its blood both during systole, both during diastole, maximum during systole, and that is clearly given in Genau. Okay. USMLE mein this question has been asked multiple times. Okay. In INI-CET it has not been asked till date, it can be asked. Okay. So, I hope all of you got it, the concept. Okay. So, you have to think of the aortic pressure minus ventricular pressure. Aortic pressure is the coronary artery pressure that is trying to push the blood into the muscles of the heart, and ventricular pressure is trying to oppose it. Okay. Got it. Okay. Next question, very easy question, no detailed discussion. So, tell me what is the answer. So, phase of action potential and the ionic basis has been given. So, first this is downward direction means entry, okay. Again this is downward direction means entry, and this is upward direction means exit from the cells. Now, it will be clear. This is the only catch that you have to understand here. So, during the phase number 0, I can understand one ion is entering into the cell, that is A. So, what is A? Right? One ion is entering in the cell. What is A? So, A is nothing but sodium entry. Then I can understand that during this phase number 2, one ion will enter and one ion will exit. Okay. Okay. So, one ion is entering. What is that ion? This is the ion which is entering. So, obviously, this is going to be my calcium, and one ion will exit, that is potassium, and the potassium exit will not only seen in phase number 2, it is also seen in phase number 3, it is also seen in phase number 1 also. So, that is why if you look at that, this exit curve is starting from phase number 1 and continue throughout the action potential, and then it is vanishing. So, this third curve is nothing but potassium curve. Got it? So, they are asking the curve C represent. So, this is nothing but potassium, potassium efflux, I am so sorry, okay, potassium efflux current. Calcium influx is C, okay, calcium influx is C. This is the actual diagram from Genau. So, this is the actual diagram from Genau. So, this is I calcium, I stands for current, calcium current, okay. Calcium is during phase number 2, and then later on calcium current decreases, and potassium current, potassium exit continue even during the phase number 3. So, this is the efflux of potassium. So, C is efflux of potassium current. So, this is the answer. Okay. So, this is a simple question, I am not taking much of the time. I hope all of you know the phases of cardiac cycle. Now, coming to some of the respiratory MCQ, very easy questions, because these also discussed in medicine. Okay. In my actual class, in my actual lecture, I have discussed the detailed version of this PV loop, but I hope all of you know that this loop is like this. This is the actual loop. This is the actual loop. So, from this loop you have to identify what is the FVC. Yes, very good. Okay. So, basic funda that you require from the PV loop is that, okay, all of you look at and try to answer. Basic concept that you require, that this lower part is the inspiratory curve, okay, inspiratory, and this upper part is the expiratory curve. Okay. So, yes, 4.5 is the answer here. Okay, I will tell you how to calculate. So, the flow volume loop is like this. Okay. So, x axis is the volume of the lung and y axis is the flow. The upper part is the expiratory flow, lower part is the inspiratory flow. If you ask the subject to take a normal inspiration, normal, so subject will take a normal inspiration, flow will increase, then the flow will decrease like this. Okay, normal inspiration chal raha hai. Then if you ask the subject to do a normal expiration, so flow will increase, then the flow will decrease. This is a normal flow volume curve during eupneic breathing, not the forceful breathing, normal eupneic breathing. Okay. So, in these cases, if you measure the volume from the x axis, this is nothing but your tidal volume, normal eupneic breathing. Now, you are asking the subject, take a deep inspiration as much as possible. So, the subject is taking deep inspiration. So, this is the maximum amount of air has been entering into the lung. So, the maximum volume that you have reached in this condition, okay, or maximum capacity, whatever you say, maximum amount of air has been entering into the lung during this maximum inspiration. So, this volume will be known as the TLC volume, total lung capacity. Then if you ask the subject to do a forceful expiration, so immediately the flow, the air flow during expiration will rise to a very high level. Then the airflow limitation will be there, airflow decrease, it will reach to a minimum volume, and this minimum volume which you are reaching here is residual volume. Again you ask the subject to take a deep inspiration again this curve will go like this and it will reach to the same point. So, this is actual flow volume loop, right. So, residual volume means from here 0 point you have to calculate what is the volume, this is nothing but your residual volume, right. From this 0 point, if you calculate this total volume up to this is nothing but your total lung capacity. So, we all know the vital capacity is nothing but TLC minus residual volume, means basically if you measure the volume from here to here, okay, this is nothing but your forced vital capacity. Okay. So, if I go back to this diagram, okay, so 1 liter is the residual volume here, okay, and TLC here, this is approximate 5.5 liter. So, TLC minus residual volume is my forced vital capacity, that is 4.5 liter, right. Okay. Detailed discussion is not possible, but I hope all of you know this. Now, look at here, this is another important question. I have seen this question in multiple grand test, okay, in multiple coaching centers platform. Okay. So, this is one of the important question. So, question is a 55-year-old man has a large pulmonary embolism completely blocking the blood flow to his right lung. Okay. Which point on the VQ line? So, this line that has been given here, this is the ventilation perfusion line. Okay. Which point indicate that this pulmonary embolism has happened? Okay. A, B, C, D, E. Okay. So, what concept you require for answering this question? So, the patient is suffering from pulmonary embolism. Okay. Look at my diagram, try to guess the concept. Okay. So, this is the representative diagram of a alveolus, right. So, suppose this is my right lung, it is said, okay, right lung, okay, right lung. So, this is my right lung, okay, and this is the representation of the alveoli, and this is the pulmonary capillary. Very good, okay, pulmonary capillary. Okay. The problem is that the pulmonary capillary is blocked by an embolism. Pulmonary capillary is blocked by an embolism. Okay. So, whenever the pulmonary capillary is blocked by embolism, what will happen? Whatever air is entering into this alveoli, whatever air is entering in this alveoli, they are not going to be reabsorbed by this capillary blood. That is what is going to happen, right? Okay. So, whatever amount of oxygen is reaching into this alveoli, whatever amount of carbon dioxide is reaching into this alveoli, they are not going to be absorbed in the capillary blood, it will remain same to same in the alveoli. So, what is the partial pressure of oxygen which is coming through this inspiratory air? Means you have to think of what is the partial pressure of oxygen at the level of this inspiratory air. We call that this is inspiratory air. Please remember, inspiratory air partial pressure of oxygen is 150, approximate 149 millimeter of mercury, and partial pressure of carbon dioxide is approximate 0. So, that is 0.3 millimeter of mercury, right. Okay. So, whatever partial pressure of oxygen and carbon dioxide is here, the same air is going to reach at the level of this alveoli, and alveolar partial pressure of oxygen will be similar, that is 150 millimeter of mercury, alveolar partial pressure of carbon dioxide will be 0.3 millimeter of mercury, right. So, we have understood what will happen to the composition of the alveolar air in case of pulmonary embolism. What will be the composition? Composition will be same to same with that of the inspiratory air. Okay. And what is that composition? 150 and 0.3. Now, I am asking what is the VQ ratio of this alveoli? What is the VQ ratio of this alveoli? Ventilation perfusion ratio. So, ventilation is normal here, but perfusion is 0 here. So, ratio is infinity. So, please note down, whenever your VQ ratio is infinity, the partial pressure of oxygen in the alveolar air is increased to 150 millimeter of mercury, and partial pressure of carbon dioxide decreases to 0.3 millimeter of mercury. Why I am saying increase decrease? Because you know that normally in case of normal lung, when the VQ ratio, what is the normal VQ ratio? 0.8. When the VQ ratio is normal, then partial pressure of oxygen in the alveolar air is 100 or 104 millimeter of mercury, and partial pressure of carbon dioxide is around 40 millimeter of mercury. So, in comparison to this normal value, whenever your VQ ratio is increasing towards infinity, what is happening? Your oxygen tension in the alveoli is rising and your carbon dioxide tension in the alveoli is decreasing. Getting my point? So, whenever there is an embolism, composition of the alveolar air will be similar to inspiratory air, increase in oxygen tension, decrease in carbon dioxide tension, right. Okay. Now, we will look at the opposite condition also. It has not been asked in the question, but look at this concept is required. Now, suppose another condition where this is the alveoli, okay, and this is the capillary blood. Okay. In this diagram, I am assuming that there is no problem in the blood flow to the pulmonary capillary, but this alveoli is obstructed by a foreign body, by a tumor, anything which is obstructing the bronchus or bronchiole, means ventilation is 0. So, in this alveoli, what is the VQ ratio? So, ventilation is 0, perfusion is maintained normally, okay, because there is no problem in the blood flow. So, the VQ ratio is also 0. So, in the VQ ratio is 0, composition of this alveolar oxygen and carbon dioxide, how much it will be? Please remember, there is an explanation for this. It will be same to same with that of the venous blood composition. So, the blood which is reaching here at the level of pulmonary capillary, that is the venous blood. Venous blood composition, partial pressure of oxygen is 40 and partial pressure of carbon dioxide is 46, right, or 45, whatever, according to Guyton 45. So, I can understand that alveolar gas composition will be same to same, that is the partial pressure of oxygen will be 40 and partial pressure of carbon dioxide will be 46, Because whenever the partial pressure of the venous blood is matching with that of the alveolar gas, then there will be no transport of gases across this alveolar membrane. Okay. Because both the partial pressure is same. Same means there will be no diffusion, because diffusion occurs due to partial pressure gradient. So, here the diffusion will be stopped. So, I can understand that in case of obstruction of the bronchus or bronchioles, the composition of the alveolar air is similar to venous blood composition. What is the VQ ratio? VQ ratio is 0. So, I can understand that from this normal VQ ratio of 0.8, if the VQ ratio is decreasing towards 0, then oxygen partial pressure in the alveoli is reducing and carbon dioxide partial pressure in the alveoli is increasing. Are you getting the gist? That if the VQ ratio from normal, if it is rising towards infinity, then oxygen will rise in the alveoli, carbon dioxide will decrease. More rise, more increase. Okay. Maximum is 150. And if the VQ ratio is decreasing towards 0 from normal, then oxygen will reduce, carbon dioxide will increase. Got it? With this basic concept, I am coming back to this curve. Okay. So, this is normal given in this question. This is normal given in this question. So, this normal means VQ ratio, this is 0.8. Okay. Oxygen is 100, carbon dioxide is 40. If I go towards infinity ratio, then what will happen to the partial pressure of oxygen? So, here this point number E, here the VQ ratio is infinity. How do I understand? Look at x axis is what? X axis is oxygen, okay. Partial pressure of oxygen, what is that? 150 here, okay. And what is the carbon dioxide? This is 0. So, this VQ ratio infinity means here I am finding out partial pressure of oxygen, here is 150, partial pressure of carbon dioxide here is near equal to 0. And if the VQ, so VQ ratio is increasing toward this side, and if the VQ ratio is decreasing towards this 0, so at this point number A, VQ ratio is 0. So, what will happen to the partial pressure of carbon dioxide? Look at here, partial pressure of carbon dioxide is 45. What will happen to the partial pressure of oxygen? 40. So, this is 40, 45, this is VQ ratio 0, partial pressure of oxygen is 40, partial pressure of carbon dioxide is 46. Getting my point? So, this is the curve they are asking you here. So, question is, in this case of pulmonary embolism, VQ ratio, okay, of alveolar gas correspond to which point? Your answer is point number E. And this question has been taken directly from this curve which is given in Guyton. Okay. So, look at this curve from Guyton. Okay. Look at this curve from Guyton. So, this is VQ ratio normal. Okay. This is VQ ratio infinity. It is given what is the partial pressure of oxygen, what is the partial pressure of carbon dioxide, and this is VQ ratio 0, partial pressure of oxygen, carbon dioxide is given. Right? I hope all of you got it. Okay. So, please give me a thumbs up whether you get it or not. So, VQ ratio is decreasing and increasing, what will happen? So, this is a case of embolism and this is a case of bronchial obstruction. Right. Okay. Got it? Okay. So, we are going to the next question. So, look at the next question. Hello. Okay. So, all of you look at. So, you have to calculate the compliance of this normal person. So, this is the normal person curve. Okay. So, we have to calculate the compliance from this curve. Okay. So, look at how to calculate. So, first of all you look at this normal curve, okay, and this normal curve, this is the rising portion of the curve. So, first you take 2 points on this rising portion of the curve. Okay. So, this is one point, okay, I am dropping on perpendicular from here, and that perpendicular I am extending onto here, okay. And then I am dropping another perpendicular from this 3 number, and that I am extending onto the x axis, right. So, x axis is what? X axis is nothing but transpulmonary pressure, okay. So, transpulmonary pressure here is changing from this to this, means this is delta p, okay. And for the change of this transpulmonary pressure, how much volume of the lung is changing? This is nothing but delta v. That is the only thing you have to do, okay. So, from this rising portion of this curve, you have to take 2 point and you drop perpendicular from those 2 point, okay. So, here you can find out that the delta v is 3 liter to 5 liter. So, delta v I can understand from here 3 liter to 5 liter. So, basically 2 liter, okay. So, 2000 ml, 2000 ml, and delta p from here means this is maybe 5 and this may be approximate 15. So, 5 to 15. So, delta p is 10 centimeter of water. So, we all know that compliance is equal to delta v upon delta p, okay. So, delta v is 2000 and here it is 10. So, this is nothing but 200 ml per centimeter of water, got it. So, this way you have to calculate the compliance of this curve, okay. So, here it is 200 ml per centimeter of water, okay. My mobile is switched off. Okay, great. So, now we are moving on to the next curve. Okay. So, all of you look at this curve and try to answer. So, here a lab technician was measuring the GFR and renal plasma flow using inulin and pH clearance from a patient. He plotted the clearance curve of inulin and pH. Which of the following is true about this observation? So, in this curve you are looking at the clearance curve, y axis is clearance, okay. You look at the number on the y axis, okay. Clearance number look at, okay. So, I can find out that this curve B, okay. What is the number on y axis? It is in and around a little more than 100, okay, little more than 100. So, I can understand that this clearance curve B indicate clearance of these substances is little more than 100, means approximately B is clearance of around 125 ml per minute. 125 ml per minute is GFR. We all know that the GFR is measured by clearance of which substances? Inulin. So, curve B is inulin curve, right. Then look at this one. This curve indicate that the clearance of this is more than 600, little more than 600. So, we know that A curve clearance is little more than 600 ml per minute. What is 600 ml per minute? What is 600 or 625? That is nothing but renal plasma flow, and renal plasma flow is measured by clearance of which substances? PAH, para amino hupric acid clearance, right. So, from these two I can easily answer this question, although you can ask that what is curve C? Curve C is the clearance curve of glucose, okay. So, glucose curve glucose clearance initially it is 0, later on clearance increases gradually, right. So, this is glucose clearance curve. So, now you can easily answer. So, curve A is the PAH curve. So, curve A is renal plasma flow, curve B is GFR. So, this is absolutely true. Curve C is no, curve B is RPF, no, no, no. So, this is not my answer, this is not my answer. So, answer is C. I hope this is clear, okay. So, this is easy question, multiple times the question has been asked, okay. So, you can go through this question, okay. Now, next question is coming in front of you. So, this is question related to the GIT, okay. Look at this diagram, new question, and try to identify the motility, okay. So, motility of different segment of the duodenum, jejunum has been recorded from a human subject. Identify the type of motility from this curve. This is a new question, but any time the question can be asked, okay. Now, the answer of this question is migratory motor complex. Okay, migratory motor complex. How I will understand? You have to identify that migratory motor complex, it start from which part? It start from the mid part of the stomach. So, migratory motor complex, it start from the mid part of the stomach, okay, and it ends at the level of terminal ileum, at the level of terminal ileum. Getting my point? So, here they have recorded this motility from duodenum and different parts of jejunum. So, the motility, migratory motor complex, it start from stomach and it sweep away all the content from stomach towards the terminal ileum. Means sequentially the contraction will be seen from stomach, then onto duodenum, then ileum, and then it will move on to the terminal ileum. Sequence of contraction. So, if you look at this diagram, two red broken line has been given. What is that broken line is saying? This broken line is saying that here is the strong contraction, this strong contraction is progressing onto different parts along with time. Over time the strong contraction is progressing, and in between this strong contraction there is no much contraction at all. So, this is typical of migratory motor complex, which is a fasting motility which starts 90 minutes after last food, and the contraction has 3 phases. Okay, that 3 phases are important. So, migratory motor complex has 3 phases. One is quiescent phase, right? So, one is quiescent phase, phase number 1 means there will be not much contraction during this phase. Then phase consists of small irregular contraction that do not propagate. Small contraction will start, that is known as the phase number 2. So, phase number 1 no contraction at all, then phase number 2 irregular contractile activity will be seen, and phase number 3 means strong contraction. So, whatever we were seeing in this previous one, I told this is strong contraction, this is basically your phase number 3 that you are seeing. I will show you another diagram from Genong. So, this is the diagram which is taken from Genong. Okay. So, this is the phase number 3 strong contraction. You can find out that this is progressing along the different parts of stomach towards terminal ileum. So, this is stomach to distal ileum. So, this is strong contraction progressing from one part to other part of the GIT, right. So, phase number 1 means the contraction is not seen at all. Phase number 2 means irregular contraction you are finding out here, irregular contraction you are finding out here, and phase number 3 means strong contraction you are finding out here, right. And in between there is a gap of 90 to 120 minutes. So, you can find out here there is a gap of 90 to 120 minutes where there is no activity. Okay. So, if you take meal in between, meal is a inhibitory for this motility. Take meal, the migratory motor complex will stop, and then if you do not take any meal for the last 90 minutes to 120 minutes, again this migratory motor complex will start from here. Once a migratory motor complex sweeps out content to the different parts, another or second migratory motor complex will start at an interval of again 90 to 120 minutes. So, it will start 90 minutes after last food, and the interval between two migratory motor complex is again 90 to 120 minutes, right. So, this is all about migratory motor complex. I hope you got these different phases, and if this image is given, I hope you will be able to identify, right. Now, next question is here, few more questions are there. So, electrical activity from a segment of mammalian small intestine was recorded, and a substances was added at point Y. Which of the following substances correspond to Y? Okay, that you have to identify. Okay. So, whatever you are seeing here, this is nothing but your basal electrical rhythm. This is nothing but your BER. Okay. Whenever you add some stimulus, okay. So, BER is nothing but resting membrane potential. So, if I draw here, so this is BER, suppose this is BER, basic electrical rhythm, which is generated by interstitial cells of Calls. Basic electrical rhythm cannot produce contraction, but suppose you have given a neurotransmitter in the form of acetylcholine. This BER will cross the threshold, and whenever BER is crossing the threshold, it will produce few action potentials, and this action potential will causes contraction of the GI muscles, and contraction means there will be more tension in the GI muscles. So, whenever you give acetylcholine, action potential will appear and contraction of the GIT will appear. If you give epinephrine or norepinephrine, what will happen? This BER will go below the threshold voltage and action potential will disappear, and whenever the action potential is disappearing, contraction is not seen, means there will be full relaxation of the GI muscles. So, this is the basic concept that you require, okay, to answer this question. So, I can understand here that whenever you are adding these substances Y, right, okay, the action potential is disappearing, and action potential disappearing means the contraction is vanishing gradually. So, you can see here no action potential here, no action potential means no contraction. That is why you can find out that the tension is near equal to 0 in this curve. So, obviously, this Y is nothing but epinephrine or norepinephrine, your answer is adrenaline. If you add acetylcholine, KCl, BACl, any of these substances, you are going to see this X. So, if you have to identify X, any of these substances, most commonly acetylcholine in the GIT normal cases, but experimentally if you add KCl also, BACl also, then also this similar kind of X phenomena, means this action potential is going to appear and contraction will appear. This is the answer of the question. I hope you got it. This kind of question has been asked in INI-CET examination multiple times. I hope you got it. Okay. So, my mobile is switched off. I am not able to see what you are replying, but I hope you are understanding. Okay. No one is outside. So, you can see here that this is cholinergic stimulation, this is adrenergic stimulation, and this is the diagram which is given in the question. Now, one of the most important thing that you have to remember, that what is the rate of BER, what is the rate of BER in different part of GIT. This has been asked multiple times in MCQ. So, please remember stomach is 4, okay, duodenum is maximum 12, proximal jejunum is 11 to 12, distal ileum is 8, cecum and sigmoid colon, the rate is given. This is a must know area, you have to remember this rate for your INI-CET examination, right. Okay. Next question is coming here. So, look at this MCQ, try to answer. So, effect of different thyroid hormone in plasma during starvation is shown in the following curve, curve B indicate. Okay. So, I am discussing this question directly. We know that the thyroid gland is dominantly producing which hormone? All of you know, that is the T4. Amount of T4 which is produced by thyroid gland is maximum, but thyroid hormone T4 is not the most active hormone. Most active hormone is T3. So, this T4 in the peripheral tissue at the level of kidney, at the level of liver, this T4 mainly converted to T3, okay, and also converted to reverse T3 or T3, reverse T3. Between these two, we all know that this T3 is the active and this reverse T3 is inactive, right. So, most of the action of thyroid hormone is due to this active component T3. T3, what is the action? It increases the metabolic rate, basal metabolic rate, it increases the oxygen consumption of the body. Now, when the person is on starvation or when the person is suffering from sepsis or any kind of major trauma, sepsis, trauma, starvation, body is not getting adequate amount of energy. Will you want to increase the amount of T3 hormone in that condition? Will you want to increase the T3 in that condition? Answer is no. If you increase the T3, more amount of energy consumption will be there, more oxygen consumption will be there. So, what will you want when the person is starving? You want to reduce the active thyroid hormone. So, you are going to reduce active hormone, and if you are reducing active, T4 generally does not decreases in the initial part. So, whenever you are reducing the active component, proportionally the inactive component will rise. So, they are the mirror image of one another, one hormone will decrease and one hormone will increase. So, from this curve I can now identify that this curve B is decreasing at the onset of starvation, and proportionally the curve C is increasing. So, I can understand that this curve C is nothing but the reverse T3, right. So, this curve C is nothing but the reverse T3 and this curve B is nothing but the T3, right, reverse T3 and T3. And what is curve A? I can understand that the curve A initial part there is no much decrease, but later on there is severe decrease. So, this curve A is nothing but T4, right. So, you have to identify what is curve B is nothing but T3, got it. I hope this is clear to you. So, this is an important curve which has been asked already in AIIMS entrance examination, got it, okay, great. Now, next MCQ, okay. So, next MCQ is here, look at the question and try to answer. An experiment is conducted in which ADH is administered at 3 hours. So, first I am looking at this hour 3 hours. So, this is 0 hour, 1 hour, 2 hour, 3 hour. So, I am following some patient and some normal person over time. Okay. So, whenever I am following, I can find out that this patient A and patient B, during this first 3 hours, I am following what is their urine output. I can understand that A and B patient has huge urine output, okay, normally. Okay, I am following, I have not given any injection, and if I look at this patient or normal subject whatever C and D, their urine output is less, I can find out here. Okay. So, if I have to understand that A, B, C, D among these 4 patients, some of the patient are suffering from diabetes insipidus, I can easily understand that between A and B they will be diabetes insipidus or maybe both are diabetic insipidus. Okay. Now, I have to differentiate that which one is central diabetic insipidus and which one is the nephrogenic diabetes insipidus. So, we know that the central diabetes insipidus means ADH production is deficient, but there is no problem of ADH to act at the level of your kidney. So, ADH function at the level of kidney is normal, but what is the problem? Central diabetes insipidus means ADH is not produced adequately by the posterior pituitary or from the hypothalamus, synthesis is reduced. So, that is central diabetes. So, if you give injection or administer ADH externally, you are giving injection of ADH, will the ADH be able to act on this central diabetes insipidus? Why not? It will act. What it will act? It will act at the level of kidney collecting duct, it will reabsorb the water. Whenever you reabsorb the water from the urine, what will happen to your urine volume? Urine volume will decrease. So, if these two are the diabetic insipidus patient, central diabetes insipidus patient means whenever you are injecting ADH, your urine volume is going to be reduced, and this B is nothing but central diabetes insipidus, right. And even after injecting ADH, if the urine volume is not changing, that means ADH is not able to act on its receptor at the level of kidney, V2 receptor, right, and that is nephrogenic diabetes insipidus. So, probably this is the nephrogenic diabetes insipidus. So, answer of this question, central diabetes insipidus is nothing but curve number B. Beautiful question, beautiful curve. I am telling you, this kind of question you are going to get in future examinations, right. So, this is, I hope you got it. Now, next question is a repeat question from AIIMS entrance examination. Try to answer the question. The graph below shows the normal rate of synthesis of various chains of hemoglobin in utero and after birth. Gamma chain of hemoglobin is indicated by which of the following? Okay, gamma chain is indicated by which of the following? So, what is your answer? A, B, C, D. Okay. So, we all know that different chains of hemoglobin, okay, the summary of the different chains of hemoglobin is given here, you can read it later on also. Look at the level of embryonic stage, right, zeta, alpha, zeta, these are the alpha group of chain, and epsilon, epsilon, gamma, these are the beta group of chain. So, all of you know that embryonic hemoglobin means if the zeta is combining with okay, eta, okay, then that is known as a Gawar 1 hemoglobin, right, Gawar 1 hemoglobin. Then if the alpha 2 is combined with epsilon 2, then that is Gawar 2, and if the zeta 2 is combining with gamma 2, that is known as the Portland hemoglobin, and all of them are at the embryonic hemoglobin, right. Now, when this embryonic hemoglobin is converting into fetal hemoglobin, alpha chain is still remaining. Okay, alpha chain is also there in embryonic hemoglobin, it is also there in fetal hemoglobin, and alpha chain is also there in adult hemoglobin. But I can understand that this epsilon chain is changing to the gamma chain, although gamma chain is also there in the embryonic, but gradually gamma chain is rising in the fetal stage, and in the adult stage this gamma is replaced by beta. Okay. So, I have to identify one chain of hemoglobin which is persisting from this embryonic life, fetal life up to the adult life, that is alpha, and one chain is decreasing this gamma, and proportionally that is replaced by another chain, that is the beta 2, means this gamma and beta 2 they will have a crossover. Okay. So, now if I go back to this diagram, I can understand that this C is rising in the adult life more and more. Along with this C, one chain is falling in concentration. So, I can easily understand that this B chain, B is the gamma chain and the C is the beta chain, right, and one chain concentration is almost same to same throughout this, okay, adult life as well as. So, this is nothing but alpha chain. So, this is alpha chain, getting my point. So, now you can understand that gamma chain of the hemoglobin is by which one, that is a beta. Okay. So, this is the actual diagram, okay, that is given in this. So, this is the gamma chain. Okay. It is also present in fetal hemoglobin to a high level, then gradually it is reducing, and then it is gradually decreasing in nature, and proportionally I can understand that this beta chain is rising proportionally, and this alpha chain, it is persisting throughout the fetal life as well as adult life in a high proportion. So, this way you have to remember that how the different chains of hemoglobins are identified, right. Okay. 2-3 more questions. So, look at here in the next question. Okay. So, look at here, this is a new questions. So, which point in the figure below most closely define the following condition? Normal erythropoietin level is 10, which point indicate end stage renal disease? Okay, which point indicate end stage renal disease? Okay. So, how to identify, how to analyze this curve? Okay. So, let us see how to analyze this. So, x axis is erythropoietin and y axis is hematocrit. Okay. X axis erythropoietin, y axis is hematocrit. Okay. So, first of all in the question it is given that normal erythropoietin level is 10. So, from this number 10 I am dropping one perpendicular, it is cutting the C point. Okay. So, from this 10 I am dropping on perpendicular, it is cutting the C point. Then from there I am dropping another perpendicular on y axis. So, I can understand that when the erythropoietin level is normal, the hematocrit or the packed cell volume PCV is 40. So, in this patient hematocrit is 40 and erythropoietin is 10 and C point indicate this is the normal point. Now, if I extend this perpendicular, okay, extend this perpendicular like this, then I can understand that this D and F hematocrit is more than normal or less than normal. D and E indicate hematocrit is also normal, erythropoietin is also normal, right, and E indicate erythropoietin is high, but hematocrit is low. This is the way to identify, getting my point. So, now I have to think of that if this is the scenario, okay, D indicate and F both indicate that erythropoietin is also high, hematocrit is also high, but F means erythropoietin is very high and hematocrit is also higher. So, I have to think of a condition F. If I think of F first, F indicate erythropoietin is hugely high, and if the erythropoietin is high, it will stimulate the RBC production, RBC production will be higher. So, polycythemia will be there. So, this is secondary polycythemia due to increased erythropoietin production. You know that secondary polycythemia means this can happen in case of high altitude subject also, in case of high altitude also, or due to certain tumor like cerebellar hemangioblastoma, okay, hepatocellular carcinoma, those tumors also produces huge amount of erythropoietin where erythropoietin is high, and because of which secondary polycythemia will occur. So, F point indicate secondary polycythemia. D point, here the hematocrit is little bit higher, erythropoietin is slightly higher, both are above normal, but just above normal. So, this is seen typically in case of trained athletes, okay, trained athletes, because whenever they are doing vigorous long duration exercise, there will be a chronic hypoxic stimulation to their body, which will increase their erythropoietin as well as their hematocrit level, right. Okay. Now, coming to the E, E indicate although the erythropoietin is very, very high, but bone marrow is not responding to that erythropoietin higher level. Okay. That is why the patient has a low hematocrit, the patient is severely anemic, but that is not responding to huge amount of erythropoietin, or because of the anemic, the erythropoietin feedback is not there, so erythropoietin has been increased, and this is typical of aplastic anemia. Aplastic anemia, all of you know the features, okay. Aplastic anemia. So, bone marrow, okay, aplastic anemia, although pancytopenic feature will be there, the erythropoietic series is not responding to the erythropoietin level, right. So, that is why the severe anemia, although erythropoietin level is very, very high. Now, coming to this B, B indicate hematocrit is high, but erythropoietin is low, okay, and A also indicate erythropoietin is low, but hematocrit is also low, right. So, this A indicate this is nothing but the person is suffering from chronic kidney disease. This question is asking about the chronic renal disease, and this is the answer A, chronic kidney disease, because you know that in case of chronic kidney disease or chronic renal failure, the patient is anemic. Why the patient is anemic? Because the person kidney is not able to produce adequate amount of erythropoietin. So, because the erythropoietin is low, the person is anemic, and that is typical of A. And this B, although the erythropoietin is very, very low, but the person is suffering from huge amount of polycythemia. So, polycythemia without any stimulation, that is a kind of malignant condition, and this is nothing but polycythemia vera, right. So, this B is polycythemia vera. Our answer here is E, our answer here is chronic kidney disease. So, answer here is A, right. E is nothing but aplastic anemia, that we have already discussed. I hope all of you got it, okay. Okay. So, this is all about the questions, okay. Now, we are moving on to the next question. So, I think this is the last question for today's session. This is a repeat question which has been asked in AIIMS entrance examinations, okay. Rees-Ecker fluid is used as a diluent of which of the following, okay. So, Rees-Ecker fluid is used for platelet count, okay. It may be a new question to you, but it has already been asked in INI-CET. Rees-Ecker fluid is used for platelet count, and platelet number normally it is in 1.5 to 4 lakh. So, whenever you want to count huge cell, then you require a large pipette. So, your MBBS life, okay, first year practical hematology, RBC pipette, WBC pipette. So, first one, that the diagram which is given here, this diagram is hemoglobin pipette. So, this is my hemoglobin pipette, estimation of hemoglobin by Sally's method. This is the RBC pipette, okay. If you can look at this bulb, so this bulb size is larger, and the marking here is 101. So, 101 marking, and here the marking is same. The third one is the WBC pipette. Here this marking is 0.5, same, this is 1, and here the marking is 11. So, in RBC pipette the marking is 101 maximum marking, and here it is 11. By this we will identify which one is the RBC, which one is the WBC pipette, okay. And here this is the Winthrop tube, right. So, we have to count the platelet